Good morning. We're back, I think. I hope you agree that yesterday had some quite special moments. I thought Chris Whitty particularly was really impressive, and I felt somewhat reassured that whatever happens with coronavirus, there are some grown-ups in the room, to quote which is reassuring. I noticed we had one question for Chris Whitty and on coronavirus and two for Simon Stevens. So presumably we'd carried on like that, we'd then have had 4 and 16 and. There are some researchers who, whenever I see they've written a blog or published a paper, I will make a point of going and seeing what they've got to say, and in this particular case, it's always interesting and it's always insightful. So when I discovered that Ashish Jha was in Europe on a sabbatical looking at European health systems, I thought, let's get him to come and talk about something. And he said, well, what do you want me to talk about? And I said, well, just come and talk about something interesting, and it will, because I know it will be interesting. So we're going to focus first on what's been happening in the US reforms, but we'll also get an opportunity to ask him to reflect a bit on some of the things he's been seeing in the early stages of his grand tour of Europe. So without further ado, Professor Ashish Jha. Thank you.
Thank you, Nigel. All right, excuse me. Good morning, everybody. So, excuse me. So what I'm going to try to do over the next 20 to... My voice is not starting off quite right. Excuse me. So what I'm going to try to do over the next 20 to 25 minutes is cover the landscape of what's been happening with U.S. health reform in the last decade, what is happening now, and where things are going. And my hope is that it's a nice segue into a conversation with Nigel about what America can and can't learn from looking at European health systems. And I've organized this talk by really thinking about 5 common myths that I have seen over time about where the state of U.S. healthcare is. So let's get started. And I'm going to basically try to talk about Obamacare and 2 myths around Obamacare. Then I'm going to talk a little bit about what's happening under the Trump administration and lay out what I think is a commonly held belief. Then I'm going to spend about 2-3 minutes talking about what the main myths are about American healthcare spending and why it's so out of control. And then the myth number 5 is hard to argue it's a myth because it's a prediction about the future, and maybe it's not a myth. So we'll do that together, and you guys can tell me whether you think it's a myth or not. All right. So why do we have a lot of myths about Obamacare? And when I think about this in the American context, and I talk to policy people in the U.S., basically most people's views of Obamacare come out to one of 2 ways of looking at things. One is this is great. This has really solved all of our issues. Obamacare is working. It's doing a great job. Here's a picture of a smiling president. Great picture. And the sense that we finally made real progress on American healthcare. There's the other view, which is it's an unmitigated disaster. And it has destroyed the fabric of our society. And we have to uproot it and get rid of it. And these 2 views continue to sort of dominate the American health policy landscape. And what I'm going to try to do is lay out what I think is really to look at the facts and say what is happening with Obamacare. We're approaching the 10th anniversary. And there are lots of ways of summarizing what a decade of Obamacare has meant. And I'm going to try to take this on by covering it in 2 ways. First is a myth that is widely held by the left and right, which is that the ACA, Obamacare, was a hodgepodge of policy ideas. I know almost nobody who thinks it's an elegantly crafted bill, surgically targeted towards the problems of America. Whether you're on the left or right, you tend to look at this and say, what a complete mess. Why would anybody create a bill like that? So I'm going to argue that that's actually a myth and that there's good reasons to think that this is an elegantly crafted bill. And so let's talk about that. Let's imagine it's February 28th, 2010. So exactly a decade ago from today. By the way, you guys probably know the ACA was passed on March 20th, 2010. So we're getting very, very close to the 10th anniversary. If you looked at the problems of US healthcare in 2010, you would talk about the problems around access, problems around costs, and problems around quality. By the way, same thing in every country in the world, right? But if you said, well, what are the specifics back in 2010? we had about 47 million people who were uninsured, and another 30 to 50 million who were underinsured. So close to 30% of Americans who are either uninsured or underinsured. And then we're staying with 2010. If you ask the question, who were these people? Who's uninsured and underinsured? They basically fell into 4 categories. There were young people, there was the working poor, there were chronically ill people with pre-existing conditions, and there were undocumented immigrants. Those are your 4 buckets of people who were underinsured or largely uninsured in America. And so if you look at the ACA or Obamacare, it basically was 2 bills in one. The first one focused on access. We were going to expand coverage. And I'm going to talk about both of these in a second in more detail. The second one was around cost and quality. So if we just focus on the first, on the issues of access, and ask what's in Obamacare, I'm assuming that most of you have heard some version of what are the major features of the Affordable Care Act. I think of the major features as having kind of a few components. First was that people under 26 could stay on their parents' health insurance. There was Medicaid expansion for people who were really poor. FPL stands for Federal Poverty Line. And then there was a series of things around insurance exchanges, community rating, essential health benefits, individual mandate, that I tend to call insurance reform. Basically, the ACA created a whole different way of buying and selling health insurance in America. So really 3 major efforts. Excuse me. And as I said, most people look at this and say, this is really messy. This is really complicated. Why do this in such a complicated way? And if you look again at who was uncovered in 2010, I told you it was young people. And so this policy of people under 26 staying on their parents' insurance was really meant to pick off that group. We had the working poor, and the Medicaid expansion was targeted towards them. And then we had chronically ill people with pre-existing conditions, and we had insurance reform and exchanges that was targeted towards them. The one group that we did leave out was undocumented immigrants. The ACA did nothing for that. And so I look at the ACA and its components, and my basic argument is they looked at who was there, who was missing coverage, and then created very smartly targeted policies that went after each group to try to provide coverage for each one in a cost-effective way. And you can ask the question, well, did it work? Did it make a difference? And if you look at the US uninsured rate over the last 2 decades, basically what you see is that we have been hanging out about 15, 16% for quite a long time. And then here we are at 16% when the ACA is passed. And then here's what happens. So 2 points from this. One is we almost halved the uninsured. And if the Medicaid expansion, which was supposed to be national, actually had happened in states like Texas and Florida, 2 of the biggest states that haven't expanded Medicaid, that 8.6% would have fallen to about 5 or almost 4%. The other point on this is that the Trump administration may be the only one in modern history that has managed to increase the uninsured rate during a time of economic boom. It's actually a pretty hard thing to pull off. But they have managed through both incompetence and maliciousness to undermine the ACA enough that the uninsured rate has gone up. And there's some reason to believe that in 2019 and 2020, this number is going to continue to rise. Okay? So that, to me, is the argument for the ACA on coverage has really worked pretty well. It's got issues. We got to make more progress. Let's talk about healthcare spending. So if you look at healthcare expenditure in the US, you've all seen versions of this. Healthcare spending before the ACA, so 2010 again is the marker for the Affordable Care Act, had been rising faster than the economy. The only point I want to make on this is in billions of dollars. So we were at about 2.6 trillion back in 2010. If you look at spending growth, one of the key points that should become obvious is that spending growth was starting to slow down before the ACA. So a lot of people who come and say the ACA has made a big difference in spending growth are not really actually looking at what was happening right before. And the ACA did a whole lot of things, and I'm not going to get into a lot of details here because I could easily give a 45-minute talk on delivery reform in the ACA. But it made a bunch of efforts to change how we pay things, like value-based payments, put in a bunch of new accountability programs like ACOs and bundled payments, and it enabled innovation through a new center at Medicare. And one of the things that the advocates, the people who love to say the ACA is working, one of the things that they love to talk about is how the ACA has really slowed healthcare spending growth. And there are lots of charts you can use, but I believe, in my opinion, that this is largely a myth. And the easiest way to see this in my mind is to begin by looking at the national health expenditures over the last 13 years. And if you look at the pre-ACA era, that's what was happening. And if you look at the post-ACA era, now if you can see a bending of the cost curve and healthcare spending slowing down in that graph, you have better eyes than I do. I don't. In fact, there's a little inflection up, and that represents bringing about 20, 25 million people into the healthcare system through coverage. When you cover people, they spend more money because they have health needs, and health needs addressing them costs money. So the ACA, in my mind, has had little to no impact on healthcare spending. And this is just growth before versus growth after. The other major thing the ACA did, of course, was try to do a whole bunch of quality reform efforts, pay-for-performance programs, a whole set of them, and they have largely failed. And again, I'm trying to summarize about 150 studies with one line, which is difficult, and you'll have to trust me, but I'm happy to get into it in a conversation after. But if you look at this whole set of hospital VBP, readmissions, hack penalties, et cetera, et cetera, et cetera, the average net effect of all these policies is zero. They've had no impacts on quality and cost. But actually, I shouldn't say the average net effect has been zero. They have had effects. Most of the penalties have gone to safety net hospitals and teaching hospitals. So while they have not improved quality, they have penalized people who take care of poor and sick people. You could argue it's not exactly the effect we were going for. There are areas where the ACA has made a difference. Where we've seen real progress is on bundle payments and accountable care organizations, and I'm happy to, again, get into more details on any of this. But the bottom line is that there are areas where we're starting to see small gains, small improvements, but there has not been any major national impact on spending or quality coming out of the ACA. And what's ironic is a lot of people who are advocates of the ACA say, well, you know, everybody focuses on coverage, and we haven't made a ton of progress there, but where we have made real progress is on cost and quality. I actually think it's the opposite. We've made real progress on coverage, which is great. We have got to do more. But we've made very little progress on cost and quality. At least that's my reading of the data. Myth number 3, and this is the one that will probably get me into a little bit of trouble, is that the Trump administration has done nothing good on health policy. So when we talk about Trump administration's efforts, it's usually headlines like this: healthcare defeat is a stunning setback for Republicans. They spent years trying to repeal and replace the Affordable Care Act, right? And every single time you thought that that repeal effort was dead, somehow they would once again come up with another way to try to repeal the ACA, and it would get very, very close. And each effort has failed, and I think each effort has failed, has been a political disaster, and that's because they don't have a replacement plan. And it's really hard to take coverage away from millions of Americans if you have no plan to do anything about an alternative. And this is the thing that has gotten all the attention. But there have been a whole series of less visible efforts within the Trump administration that I think are worth at least acknowledging and lauding. And let me just say, generally I try not to be an overtly political person. I want to be very clear. I think Donald Trump himself, is a moral stain on our nation and has been an unmitigated disaster for policy in our country. I know I was going to say, was I hedging too much? I apologize. I'm not a fan. I don't plan to vote for him in 2020. But because of his incompetence and because of the inability of the White House to generate any useful policy on health care, what it has done is it has created a political space for people in agencies to do things. Now, when they've had good people in agencies, they're doing good things. When they've had incompetent people in agencies, they're doing incompetent things. And it turns out that actually at CMS, the most important health agency in America, Center for Medicare and Medicaid Services, they happen to have some good people, smart people. I don't always agree with them, but pretty smart people. And they have taken on topics that the Obama administration, unfortunately, I think refused to take on. And so they have done some really interesting work around price transparency rules, which are about to come into effect, which finally will open up and make very clear the craziness of healthcare spending in America in a way that we haven't before. They have taken the ACA, Obamacare ideas around ACOs and bundles and redoubled their efforts in some smart ways. And they've gone in directions that I wish the Obamacare, or the Obama administration had gone. They have been finally pushing for interoperability and making IT systems work better in a way that was not politically possible under the Obama administration. And they've been taking on a whole bunch of special interests around quality and safety, et cetera. It turns out that what CMS has been doing is pretty good. And in many ways, they've been able to do things that the Obama administration wasn't able to do. Because in any administration, you have the wonks and the political types, and they fight it out, and you come to some sort of a compromise. But the White House is such a policy disaster under the Trump administration that the wonks are getting to run the day. And sometimes that's terrible, but sometimes you can actually get something useful out of it. And so that's what I think has been happening here. And it's not popular to say that the Trump administration is doing something useful. But I think when it comes to American health policy, they actually are. All right, couple more, and then we will wrap up. So one of the standard myths of American healthcare, I'll get to that, is that the main problem of US healthcare is overutilization. And this is where I'm going to get a bit into international comparison. So you guys have all seen versions of this slide. Here's American healthcare spending as percent of GDP compared to other countries. This is actually the slide that every health policy talk in America begins with. We spend more than everybody else. And those countries are, Switzerland's number 2, we know, and France and Germany and Sweden, et cetera. So the question is why? Why does America spend so much more than everybody else? And if you grab a random health policy expert in America from the political left or the political right, you essentially get one of these answers. That the problem is fragmentation or fee-for-service, or it's for-profit greed, or it's lack of transparency, or if you're on the more right side of the political aisle, that it's lack of enough skin in the game, that people are overinsured, and that means they overutilize. But what has been amazing to me is the remarkable degree of consensus in American health policy, that the problems of American healthcare spending are problems of overutilization, just doing too much. And so the only equation I have this morning is this one, which is total spending is quantity times price. And the broad consensus has been that the problem is quantity, that we have a high quantity healthcare system that is out there going crazy, doing all these services that people don't need. So the question is overutilization the main problem of US healthcare? Do we actually use more care than other countries? So let's talk about this. And I want to just talk a little bit. This is my kind of one foray into overutilization, and then we'll wrap up with predictions about the future. So one theory has been that we are quick to go to the doctor, that Americans, the moment they get sick, the moment they have a little back pain, a little sniffle, they're off to the doctor. This is something that people talk about all the time in American policy. So this is from some work that we did recently where we looked at American healthcare utilization compared to other countries. And what you find is that when it comes to doctor visits per population, the mean across these 11 countries is about 6.5 per population. The average American sees the doctor 4 times a year. By the way, I've always been struck by what's happening in Japan and Germany. Many of you may know this. But the average Japanese goes to see a doctor 13 times a year. It's remarkable. It's once every 4 weeks for the average. And for every 25-year-old Japanese who never goes to see the doctor, there's somebody else going once every other week, right? Even Germany is quite high. And America is really on the low end. So when I show this data to people, they say, actually, that's the problem. You see, we don't go to the doctor enough. We knew that. And that means not enough prevention, not enough primary care, and though we're spending all of our time in hospitals. In fact, I heard this earlier this week from an expert said, well, the problem of American healthcare is not enough prevention, not enough primary care. And that's why the hospitals are always full in the US. So we said, well, we should be able to look at that. So here's what hospital discharges per population look like. And here's the mean across all these countries. And it turns out America's actually below average. By the way, Germany, keep your eye on Germany. Actually, it's an important phrase that we could always use, but keep your eye on Germany. Sorry, I shouldn't have said that. Really high utilizers of hospital care, also high utilizers of ambulatory care. But it turns out, okay, hospital discharges. And then you guys probably know this, but of all these countries, which country has the shortest length of stay? America. So combine low number of discharges with short lengths of stay, and Americans are actually spending a lot less time in hospitals than almost any other country. So fewer doctor visits, fewer hospitalizations. Some people are like, the real issue is tests and procedures. And here, there is some data. So if you look at MRIs per population, here's the mean, and here's America. We're on the high side. Germany. It's interesting. Knee replacements, America turns out, by the way, I could do this all day. I have like 35 of these, but I won't torture you. On knee replacements, America is actually number one, partly because we have a lot of obesity, and obesity is a major risk factor for osteoarthritis, which is why people need their knees replaced. So that's pretty high. And then I would have thought that the same thing would show up on the hip replacement, and it turns out actually not so much. And the Swiss and the Germans are doing a lot of hip replacements. Coronary angioplasty, another procedure that seems to get a lot of attention. Here's America, a little bit on the high side, about the same as the Dutch and the French. And there are the Germans. They're a high-utilizing country, by the way. So the bottom line is this entire story. Remember all the reforms I showed you in the ACA were all built on trying to reduce overutilization. The entire narrative of American healthcare has been that we spend too much because we do too much. And it turns out that it's not true. It's a great story, just not quite right. So we have fewer hospitalizations and doctor visits. We do more of MRIs and knee replacements, but fewer of other things. And the way I look at it is if I looked across 30 different measures of utilization, America is above average on some things, below average on other things, and on average, it's pretty average. So utilization is not the big driver of American healthcare spending. So what is it? It turns out if we go back to our one equation, there's another part of this, which is price. So if you look at prices of healthcare in America, this is total drug spending per capita. Americans don't use more pharmaceuticals than Europeans, but they pay more. And that's often the culprit that gets attention. But it turns out it's not just drugs. This is CAT scans. By the way, $85 for a CAT scan in Spain. I mean, feels to me like at that price, it's, we should all get on a plane, go to Spain, get a little abdominal pain on the way, no big deal. Just you can get the CAT scan for $85, which is remarkable. Appendectomies, here are some really cheap countries like Switzerland at $6,000, and America at 2.5 times. And I could do this all day as well, but some interesting things to think about. Part of the reason our healthcare spending is so high is because our generalist physicians get paid more, our specialist physicians get paid more, our nurses get paid more. Everybody in American healthcare gets paid more. So what is the problem of US healthcare spending? To quote a colleague of, I'm sure many of you, a mentor and friend of mine who passed away a couple of years ago, Uwe Reinhardt, it's the prices. Stupid. Policymakers have almost entirely ignored, there was supposed to be another word, ignored this issue, and that's why we've made so little progress on healthcare spending. All right, I'm going to finish up in 2 minutes just by making the following, which is that the standard line in American politics is that 2020 is shaping up to be the healthcare election, and that finally after 2020 we're going to get national health reform. And you have people, our Democratic fundraiser, who has been front runner, our Democratic front runner, and fundraiser, he's actually raised quite a bit of money, has been very, very clear that this is the time and we should look towards countries like Denmark. If you look at the reality on the ground, this is my one effort to do prediction of what's going to happen with American health policy. There are 3 scenarios of what happens. There are 100 scenarios, but 3 most likely. One is you get a Democratic president and a Democratic Senate. Could happen. Looking less and less likely each day, but could happen. I think we're going to see some efforts to introduce Medicare for all. I don't think they're going to go anywhere. And ultimately, I think what you're going to end up with is policies that strengthen the Affordable Care Act. If you get a Democratic president and a Republican Senate, which is a bit more likely, most of the policy efforts are going to be trying to shore up the Affordable Care Act through a bunch of policies. And if you get a Republican president and a Republican Senate, there will be, I think, again, new efforts to repeal the ACA. I think they're going to go nowhere because the Republicans have no consensus on what they want to do. The Democrats don't have much consensus either, but at least there's enough of a view of we've got to strengthen the ACA and then maybe try to do Medicare for all. On the Republican side, it's just a policy disaster. And so every few months, Trump comes out and says, we're going to have a new health care bill. And it never shows up because they don't know what they want to do. And so what is going to happen, I think, if we do indeed get a Republican president and Republican Senate, is all the movement towards health reform is going to move to states. And states are going to be the kind of place where you're going to see lots of innovations. You might see some states go to single payer. You're going to see other states try to unravel a lot of the gains of the ACA. It's going to be that is going to be a hodgepodge over the next few years if Trump is reelected. All right. Oops. So, sorry, I don't know why number 2 showed up first. Let me actually put all 3. So I don't think there's an appetite for radical changes. Where I think we're going to get efforts is around drugs and out-of-network billing, and I'm happy to talk about this, but these are the 2 things that have a lot of policy attention right now in the US, high prescription costs, and then we have this crazy thing called out-of-network billing. For anybody who's been following American policy, I can talk more about it, but it is really crazy, and a lot of Americans are hit by it, and I don't think either the Democrats or the GOP is going to put a lot of political capital. So finishing up, last slide, and then I know I'm over. I think the Affordable Care Act has actually provided a very strong point for American health policy reform. I believe, and I may be the only person I know who says this, but I think it was elegantly designed to target very specific issues. It has made huge progress on coverage, not enough, but big, but not done much on costs. The Trump administration has been surprisingly active on costs and quality, continuing many of the ACA ideas and pushing new ones. I think over the next few years, we're going to have to tackle prices. It's really extraordinary, the price problem of American healthcare. I don't see 2021 as the healthcare revolution year, but an evolution that I think builds towards a better, more universal system. All right. Thank you very much. I'm a couple minutes over.
Thank you. Thanks for that tour of the territory. I think one of the things that people would have caught people's eye was your thoughts on ACOs, because as you'll have picked up, it's a sort of foundational idea for some of the strategy that we're pursuing. What lessons have you drawn from the ACO experiment? I know you've done a lot of research in that area.
Yeah. So I have gone from being very skeptical of ACOs to actually kind of being a fan of ACOs, because it turns out there's this thing called evidence. And when it emerges, it's worth changing your views. So ACOs, just as a quick, and I couldn't really cover it because I was trying to cover probably too much ground in that talk. There are about 500 of these entities now. They probably cover about 20% of the US healthcare population. So they have relatively large footprint. And what we've seen is that they have started really lowering healthcare spending. What's interesting and important about them is that ACOs come in 2 flavors. ACOs that have a hospital as a part of the organization, and ACOs that don't have a hospital as part of the organization. Physician-led versus hospital-led ACOs. All of the savings have come from physician-led ACOs, and the hospital-led ACOs have saved no money whatsoever. And the way physician-led ACOs have saved money is by preventing hospitalizations. And if you happen to be a hospital-led ACO, you have a real struggle preventing hospitalizations because your business model is hospitalizations. So it has sort of interesting implications for when you think about ICSs here and what's the role of the hospital. It's really what's been driving the savings has been physician-led ACOs that have figured out how to keep people out of the hospital. And that has, I think, interesting implications for how to think about some of these integrated care systems here.
So how are hospitals adapting their business models, or are they just crossing their fingers and hoping for the best?
I think it's more the latter. The other thing they're doing, and has been working quite effectively, is that they're merging. And with more market power, they can go to insurers and jack up their prices. And so what they lose in volume, they make up in price through market power. And so that's a pretty effective strategy for getting through the short run. But it has now gotten to a point where there are lots of monopolies, very high prices, and people really questioning what's going on.
In terms of the prices, I was just wondering, the GDP per head in the US is significantly higher than many of the comparative countries you're looking at. Prices are higher, pays tend to be higher, partly because health insurance is effectively part of pay packet. If you adjust for prices, how far for differences in international prices, does the US still look like such an outlier, or is it just it's an expensive place, so healthcare is expensive?
Yeah, so even when you depends on how you adjust for prices, but if you do like purchasing power parity stuff, all the stuff I showed you is actually adjusted for purchasing power parity. The way I think about it is, so I was in Geneva yesterday. Turns out Geneva's a pretty expensive place.
Oh, yeah.
Right? I stopped off at a Starbucks just as I was getting on the train. $9 for a little latte.
Yeah.
And I didn't even have the vanilla shot. Like, it was just a plain up latte.
There's a little sign that says your home may be at risk if you order this coffee.
Right,
yeah.
right.
Yeah.
And what's interesting is that an MRI in Topeka, Kansas costs twice as much as an MRI in Geneva. And you'd have to sort of think through how could that possibly be. There really is a price problem that comes out of market power in the U.S.
Is it just market power? Because I think the other thing that strikes one when dealing with the U.S. is the sort of layer of intermediary administrative function that you tend not to see in European health systems, both in terms of consultancy, advisory, but also various people helping you maximise your revenue or control your insurance costs or manage your pharmaceutical benefits.
Absolutely. So there is no doubt that from a complexity and administrative inefficiency, America really has figured out how to do this better than anybody else. So our administrative cost, depending on whichever metric you use, is about twice as high as any other country. So I think that's a part of it. I think it's ultimately only a chunk of it. I think both market power with private insurers and political power. So it turns out hospitals are almost always the largest employer in every congressional district. Congress gets reelected every 2 years. And so anytime Medicare tries to do a policy where they cut prices for their doctors or hospitals, Congress is happy to step in and say, please don't do that.
So they don't even, we talk about having a sort of a window to make major changes in hospital. We have 5-year electoral terms, of course. Which
about
means
6 months.
So you got it 6 months.
Yeah. Right after the election, 6 months of that first year, you can do things. And if you miss that window, we're back to election year.
The other striking, apart from the diagnostic prices, which were truly jaw-dropping, was the pharmaceutical prices. So there is a ban on Medicare negotiating with pharmaceutical companies, but even so, those prices are quite remarkable.
They are.
Is that a reflection of the politics and the political power of the
pharma industry? Yeah, so pharmaceutical prices problem in the U.S. come in two flavors. There's the crazy high prices of brand name drugs, new drugs that come out because nobody's negotiating, and so if you want the drug, you pay basically whatever the pharmaceutical company wants. And then we have the often very, very high prices of generics. So about 85-90% of drugs sold in the United States are generics. But what has happened over time is with generics, often their prices are initially too low. There only are one or two companies making them, let's say 2 companies. And then for whatever reason, one gets to buy the other one, and then they realize one morning that they have a monopoly, and they jack up their prices by 1,000%. And there's no kind of political or regulatory response to that. So that's one set of issues that I think is very, very politically solvable. The issue around brand name drugs and not negotiating has meant that America really is the driver of both profits and innovation. To the extent that you think profits drive innovation, we can talk about that. And so the big fear is if Medicare starts negotiating, you're going to see profits come down, which almost surely you will. And the line that pharmaceutical companies use is that you'll see less innovation. And the answer is you might. I don't think there's a free lunch here. But how much less, what kind of innovation will we not see?
I seem to remember Donald Light, an article in BMJ suggesting that quite a few pharmaceutical companies spend more on marketing than they actually do on product development. So
and so the question, do we think that if they get less profit, are they going to reduce their marketing and go more towards product development? Probably not. There's no reason to think that. There's been some very good work recently that asks the question, these are not sort of simple, less profits, less innovation. It's what innovation will we miss out on, how important is it, and how much will we save, and is it worth it? Yeah. The same kind of questions that every other country asks. And I think the US is finally starting to ask it. I don't think under a Trump administration anything is going to change in 2021. But under a Sanders administration, you might get political authority to negotiate.
Interesting. Let's take some questions before I come back and ask you about your journeys around Europe. Masood, do you want to stick your hand up so they can see you, if you would? All right, good.
Thank you. That was an excellent speech. And one thing about the innovation and drugs, I'm ophthalmologist, and most of our innovation happen in America. And what I've seen, those American companies then have a global reach, which then bring for taxpayers of America significant revenue. So if you factor in the initial high-cost drugs or innovation or lenses, so on and so forth, you will get more than that through global reach and global market. And I didn't see that in that analysis.
Mm-hmm. Sure. Any other points? Any other questions? Yes. I can't see who that is, but say who
Hi,
you are.
good morning. Rob Smith, Health Education England. I'm just wondering, are supply side access issues material in the system? And I'm thinking about community hospital closures and the kind of maldistribution of workforce in rural and remote areas.
Yeah.
And are there policies around scope of practice that might be being explored to address some of those things? I follow some of your researchers, and things like the opioid crisis in particular seem to be triggering some discussion about scope of practice in remote and rural areas and how that might apply to us. Now, we think Lincolnshire's remote, but we can see the cathedral from the A1. I know America's very different.
Yeah, different type of remoteness. Good, okay. Do you want to deal with those points? And
Yeah. So, and that's why I think the demonization of the pharmaceutical industry, look, pharmaceutical industry behaves very badly on multiple issues, and I have no interest in standing up publicly and defending them. But they have been sort of singled out by the American left as sort of particularly terrible and only kind of robbing the American purse. And I think your point about that there are a lot of different benefits of what the American pharmaceutical industry does, including the fact that they are global leaders and they are out there selling, and when they bring that money back, there are tax benefits. It is an innovation engine. So I think I am more sympathetic, and of course, I always sort of think, why do we single out the pharmaceutical industry and then leave all the hospitals completely alone? The hospitals, I actually think that the American hospitals are actually a much, much bigger problem, because there's one other problem with American hospitals. 80% of them are nonprofit. And when you're nonprofit, you don't pay taxes. And so what you have is in cities, these large mega companies, corporations. Texas Medical Center in Houston has an annual revenue of $25 billion. That's a lot of money. They don't pay taxes. And so for the city of Houston and for the state of Texas, that's a huge problem. So we have kind of focused on pharma and a little bit on insurance. I think we have not paid attention to everybody else, and I think there's more benefits coming out of pharma than we know. On the issues around scope of practice, I think this is another area where, I hate to say it, but the Trump administration has been pretty good. They've been willing to push the agenda a bit more, especially to get more care out to rural areas. But I basically think the model of what can a doctor do, what can a nurse do, what can nursing aides do, these models were developed 50 years ago. And the entire point of technology is it enables people to do different work, right? That's what technology is useful for. It's not useful to take the work you're already doing and making it a little more efficient. That's fine. But it enables people to do different work. And we have not done that reconceptualization. And I hate to say it, a lot of it is because of doctor guilds and even nursing guilds. So nurses complain that doctors have this scope of practice rules that make it very hard for nurses to do things, and nurses are right about that. But then they have their own scope of practice things that make it very hard for anybody else to do anything that we traditionally think nurses should do. So everybody protects their turf, and the only people who look out for the broader public interest is the government. And again, I hate to say this, but the Trump administration has been like pushing on this. And I love that. And I worry that some point somebody in the White House is going to show up who actually knows a thing or two, and they're going to put an end to all of this. So as long as the White House is politically useless, the agencies get to actually move the ball on some things.
The advantage of being, if they're malign, it's okay as long as they're incompetent.
Yeah.
Right, okay. Good.
No, it's actually probably the biggest saving grace of the Trump administration, is that they're incompetent.
Thea, over here, and then over here. It's just Andrea. Do you want to put your hand up again? Thea? I can't see who it is, actually. The lights... no, it's no good. Yeah, there you go. Andrea, I think, is it? Yes. Yeah.
Andrea Sutcliffe from Nursing Midwifery Council. When Nigel did his presentation yesterday, and we talked about successes in policy. Top of the list was NICE. And so given your thesis that price is kind of one of the real critical issues for American politics, is there American healthcare system, is there ever likely to be a NICE for America?
It's a great question. So we have ICER, which you guys know. It's not a governmental agency, and it is doing what NICE is doing, but for the pharmaceutical side, and actually private insurance companies are using ICER analyses to negotiate prices. So I actually think we've got some movement happening in a classic American form. We're doing it in our own way. Is there any such thing happening on prices for hospitals and doctors? And the answer is no. What I do think is going to happen, there's an old saying that predictions are hard, especially about the future. But I'll go ahead and make it. I think if we're sitting here in 2025, we're going to be talking about how about 8 or 10 states have gotten very serious about price regulation and have stepped in and really started regulating price increases or maybe even cutting prices. I think that's going to happen in the classically more left of center states like Massachusetts, Maryland, Minnesota, not just the M states, some but you're going to start seeing some of that. I don't see a national agency like NICE because we don't have consensus on this, and I think which is very different than the UK. Yeah.
Say who you are.
Oh, sorry, I'm Thea Stein.
Oh, it is Thea. Sorry.
Chief Exec of a community trust in England. I'm intrigued how the concept of outcomes get played out in the American healthcare debate and how people would or wouldn't use it to justify high price. And I'm just interested to know how it gets discussed within the debate.
Yeah, no, it's a good question. And depending on which outcomes you're talking about, I mean, it's easy enough to put up like life expectancy where we're terrible. Though 2 points on life expectancy, just as a, one of the things I do in a talk about international comparisons and life expectancies, of course everybody knows America's life expectancy is much lower than most other high-income countries. But if you forget about America for a second and look at places like Minnesota, Hawaii, California, life expectancy in Minnesota is about the same as it is in Sweden, partly because it is Sweden. But California's life expectancy is about the same as Canada, maybe a little tiny bit less. So we do have those kinds of pockets and big pockets where outcomes are good. On issue of whether it's the high price outcomes thing, where people will point out is things like, if you're going to have a stroke, and I wouldn't recommend it, but if you're going to have it, America may be the best place in the world to have a stroke because outcomes after stroke are phenomenal in America compared to every other country. Partly because we have, because of our high price system, we have lots and lots of things in place that make stroke outcomes quite good overall. So people will point to that, whether we need to have neurosurgeons making $800,000 a year to achieve that. What if they only made $600,000? Could we still get good neurosurgeons? I suspect the answer is yes. So I think we can manage some prices without affecting outcomes. But people will point to data like that, and it's not, you can't ignore it completely.
Let's take a couple of other quick questions with Anita and Stephen Dorrell. Stephen, do you want to go first? No, Stephen, thank you, and then we'll come to you.
That's me.
Quickly, if you would, though, please.
Yeah, as you referred to the fact that we're developing ICSs in this country, one of the purposes of which, at least in the rubric, is to embed the healthcare system more effectively in the rest of local public services, engage with local government. And I wondered whether you think that that's something, you said that one of the outcomes of 2020 could be a more state-based healthcare system, more emphasis on state rights, whether that would be the opportunity to address some of the social determinants rather than simply regard it as an insurance system to deal with acts of God.
Okay. Do you want to take a couple more, and then I'll
take Anita, and then I'm going to come back and ask you about Europe. So, Anita.
Yeah, I wanted to ask if you see a tension between the development of the more successful ACOs and the need to focus on input prices and, to name it, physician pay. Because obviously you said the ACOs that have had most effect on volumes are ones that are led by doctors, because hospitals haven't voted against their own self-interest. But if the next real issue in value in American healthcare is input prices, the people who essentially you're putting in charge, people who would have to own, So is there a risk that ACOs perversely are making it more difficult to address the primary issue going forward?
That's a really good question. Anything else?
No, let's do those. Let's take
Okay,
those two.
so,
Yeah.
the issue around states and embedding it, I do think that's a really important way to think about health reform. What's really clear is 320 million people, which is the population of America, is too big a population to try to do a single strategy on how we're going to do healthcare delivery and then tie it to social services. So I've actually been a pretty big fan of state-led efforts and state customization. And when I see that happening here, I generally see that as a good thing. With some overlay of just making sure that there are national standards and that it's a problem in the US because state rights is a code word. So this is why things like history end up being really important. The reason why the American left hates state-led healthcare reform efforts, even though Massachusetts was that, is because the history in America is one of states' rights as a way to deny people. Well, it was really about segregation and saying, well, we should be able to have slavery or we should be able to have segregation. And so that code word is still there, and that has really big implications for whether we're going to allow states to do this. What American left likes to be able to do, and I'm part of the American left, by the way, this is not just criticism of these crazy people, I'm one of them, is we're really comfortable with Massachusetts and Minnesota doing state-based reforms. We're not so comfortable with Mississippi and Arkansas doing state-based reforms.
Yeah.
It's going to be hard to get one without the other. On the ACO issue on prices, it's a really interesting question. I haven't really thought about it so much. But what ACOs are arguing is, look, even if we're overpaying, if our prices are really crazy high, if you reduce utilization, you still save money. I always say if the problem is you're paying too much for your pizza, okay, but if you eat less pizza, that still saves you money. It's okay. Where I think the price stuff is really going to get into, is going to kick in, is not so much on primary care physician salaries. They are higher than other countries, but you're probably not going to see big effects there. It's going to be on do we need to spend twice as much in Topeka on MRIs as they do in Geneva? Could we get away with other sort of diagnostics or the neurosurgeon who gets paid $800,000? And the average orthopedist in America gets about $650, $670. That's the average.
We've got about 1 minute 30 left, according to that ticker there. So I'm going to very quickly ask you, you've been on a tour of various bits of Europe. What have you seen so far that's impressed you that you think you could take back?
Yeah. So, the motivation for this project that Nigel referred to is a line from Uwe Reinhardt, and I'll just give it and then I'll tell you my impressions. Uwe, a few years ago, was asked about Denmark, because Bernie was talking about Denmark, and what did he think of Denmark? And Uwe said, look, Denmark is wonderful, and I will take the Danish health system, but you must also give me the Danish political system. And it would surely help if you gave me the Danish people. And in a way that only Uwe could do, and he did it with his beautiful accent, and I can't replicate it. But so my goal has been to try to sort that out for a bunch of countries. And so I've obviously spent quite a bit of time in England. I'm going to head up to Scotland later. And then I've been in the Netherlands for a couple of weeks, and then I just spent a few days in Switzerland. And what is striking to me is how the narratives that we tell ourselves in England, you could not tell those narratives in the Netherlands. The kind of almost deep religious love of the NHS that is here, and I mean that in a good way, like people deeply love the NHS. People in the Netherlands, I've told them stories of people here, and they find it all completely puzzling, because for them it's much more transactional. It's much more like this is what the government's role is, this is what private insurance does. And what's interesting so far has been something that may be obvious, but it's worth understanding, is that you can get to universal coverage with high quality and reasonable price controls in a variety of different ways. But without understanding history and culture, it's really hard to take kind of big stuff and transplant it to another. The host will reject it. And finding those stories has been extremely interesting. Still early on in this journey, and I'm happy to come back at some point.
I think we'll get you back at some point and get you to reflect. So thank you very much for that tour de force. Brilliant. Thank you. Good. And now
Okay. So, fascinating, I think, tour through some of the mythologies about US healthcare. And what we're going to turn to now is exploring some of the rhetoric about healthcare in the UK. And I think we can often be a bit smug about the NHS, and I think, the NHS is here for us all. We have universal healthcare. We're going to test how true that is. So I was going back to the NHS Constitution this morning in preparing for this session. And I'm just going to read a little bit from it. The first principle of the NHS Constitution is that it provides a comprehensive service available to all. It has a wider social duty to promote equality through the services it provides and to pay particular attention to groups or sections of society where improvements in health and life expectancy are not keeping pace with the rest of the population. So that's what we think we're here to do. And what we're going to test in this session is how well the NHS actually delivers against that obligation. So we're going to explore the similarities and differences in healthcare for a number of groups of people, and groups of people that I refuse to call hard to reach. I think that's a term that's too easily used. But we want to take a positive frame on this. We want to discuss the things that the NHS can do to improve access to care for those groups. We are going to be using Slido for this session. So if you want to log on to it, the link's on the screen, the event code's on the screen, you go to the Q&A tab. And while you're thinking of your questions, I'm really delighted to introduce my colleague Miranda Davis, who's going to kick us off by talking about the work that she's been doing looking at access to healthcare for prisoners. So off you go, Miranda.
Good morning, everyone. I'm really pleased to be here today to talk to you about access to healthcare for prisoners. On Wednesday of this week, the Nuffield Trust launched our new report, Locked Out: Prisoners' Use of Hospital Care. And this report represents the first time that routine hospital data has been used to look specifically at prisoners' use of hospital services across England. So what I'm going to do this morning is talk to you about some of the key findings that are covered in the report, and also a bit more broadly about some of the things this tells us about the challenges of providing healthcare to prisoners, and also perhaps the quality of healthcare that prisoners receive. But first, why are we talking about this report as part of this wider session on health inequality? Well, I would put to you that there are experiences, circumstances and conditions that can mean that people entering prison, people in prison and people leaving prison are all at risk of experiencing inequalities in terms of their access to healthcare. So let's think first about people who are entering prison. What we know is that actually there are some common shared experiences between people entering prison and other groups within the population that we might commonly talk about when we think about inequality and perhaps vulnerable groups. So what we know is that people entering prison are more likely to have been abused as a child, to have experienced homelessness, unemployment, exclusion from school, and also to have spent time in care. And looking at homelessness as an example, around 15% of people report being homeless on enter to prison, and this compares to around 4% in the general population. So you can already see there are these big differences in people who are entering prison and perhaps other people that we might think of in the wider population. And then, what's life like in prison itself? Well, first of all, I want to put to bed the myth that's widely reported in media reports about prison and prisoners, that prison is a holiday camp. It categorically is not. This is a report from the most recent HM Chief Inspector of Prisons, and this is a line from the report, and it reads as follows: that broken windows, unscreened lavatories in shared cells, vermin and filth should not feature in 21st century jails. And I think actually we can't put it any better than that. We don't want people to be living in these types of conditions. In terms of living conditions as well, something I thought was quite interesting was that actually around a third of prisons are built in the Victorian era. And what this means is that there are some really practical problems that people living in prisons can experience if they happen to be in one of those prisons. The prison population is predominantly younger, but actually there's an increasing proportion of older people living in prison. And if you're an older person living in a Victorian prison, what I found was when I visited prisons and spoke to people, things were said to me more than once about being in prison and being an older person. Oh, I missed out on my dentist appointment recently because the dentist is on the 3rd floor and I couldn't get there. The lift isn't working. People can't navigate the stairs. Also, other really practical problems that occur because prisons, well, they weren't built to meet the healthcare needs of people, and particularly older people or people with mobility difficulties. Cell doors are not wide enough to move wheelchairs through. There sometimes isn't the equipment that people might need, like walking sticks and so on. The other three things to mention about life in prison that I really would like everybody to take away from this is the big three, really. The overwhelming impact of violence, self-harm, and particularly the availability of illicit drugs, which is debilitating for people who are living in prison and also staff in prison too, who are trying to maintain the general day-to-day running of the prison itself. Thinking about self-harm, in the 12 months to September 2019, there were over 61,000 incidences of self-harm in prison in England and Wales. And this represents a 16% increase on the previous year. And I think this is something we should all be worried about, we should all be concerned about, because it points to wider issues around conditions in prisons, the experiences of people in prison, and also how well their needs are being met. And what about life after prison? Well, these first three bullet points, they're all fairly basic things that you or I need to function in our lives as well. People need somewhere to live. They need employment opportunities, and if they have a long-term health condition, there needs to be some ability to maintain continuity of care as people move from prison out into the community. If any of these three things are not in place, and for a lot of people leaving prison, they're likely not to be. The figures on rates of settled accommodation, they're quite sketchy in terms of the numbers you can draw, but actually most people are not leaving prison to settled accommodation. If you do leave prison and you're homeless, you don't have any likelihood of getting a job, and then particularly if you have a long-term health condition, how far is the £46 discharge grant that people receive going to get them? And I think the answer to this is not very far. So what did we do in our work? Well, what we noticed was that there was a real gap in knowledge around the physical health of people in prison, and also real data-driven knowledge about the physical health of prisoners. So what we did was look at hospital data, and we looked at anonymous records for prisoners identified based on a link to a prison postcode. So we looked at how often services were being used, when they were being used, crucially why they were being used, and then we also did some broad comparisons with the general population, and some specific analysis on women prisoners and also older prisoners as well. So as a researcher, I'm going to start with a caveat that I want everyone to remember before we start thinking about any of the results. Hospital data does not tell us everything, and we need to be aware of that when we think about the actual implications of these findings and what they're really telling us. What is happening in prisons in terms of the healthcare provided and crucially how it's provided is crucial. And we also need to bear in mind the wider prison environment as well, because obviously general conditions, if the prison is on a restricted regime, all of these things will have an impact on what happens to people in prison and therefore what needs to come out of prison to go to hospital. So this is the headline slide in terms of the sheer volume of use of services. Around 12,000 inpatient admissions, about 83,000 outpatient appointments, of which around 50,000 were attended, and then lastly, around 18,000 visits to A&E. But why are prisoners tending to be admitted to hospital? So what we did firstly was look at the top 5 primary reasons that prisoners in England tended to be admitted to hospital in 2017-18. Up there at number 1, we have injury and poisoning. And this equates to around 18% of all admissions, so over 2,000 admissions a year for this reason. But what you might be thinking to yourself now is, well, okay, fine, but how does that compare to what we might see for people in the general population? And that's what we can see here. So the blue bar is our prisoner group, and the purple bar is our general population comparison group. Key thing here, there are different reasons why prisoners are attending hospital than the general population. For the general population, in our broad comparator group, cancer is the most common reason for a hospital admission. For people in the general population, they're tending not to be admitted for injury and poisoning. It's around 6% of all admissions versus this 18% in our prisoner group. So although we might not be particularly surprised that injury and poisoning is up there and it's the most common reason for admission, for me this is actually one of the more important findings from the work, because actually I think it's important to place some sort of colour and understanding about the realities of what violence and conditions in prison mean for the people living and working there. And that's what we started to delve into a bit more in the report. So what we can see on the slide here is the 3 most common types of injury and poisoning that we found in the data to affect prisoners. Up there at number 1, we have head injuries. So this is over 500 admissions to hospital a year. This includes fractured skull and facial bones, and most alarmingly as well, intracranial injuries as well. We also then have our poisoning cases, and then lastly, injuries to the wrist and hand. And in the broader report, which we'll give you a web link to at the end, you can also see similar patterns in the A&E data as well. So some people are attending A&E for these reasons, and some are ultimately having to be admitted. So to move on to another finding now that was particularly interesting and intriguing to me was we looked at emergency and elective admissions by prisoners to hospital across the course of a year. And this is what's covered in this slide here. So our top graph references the prison population, and the bottom graph is our general population comparator group. We have the months of the year on the horizontal axis, and the vertical axis is number of admitting episodes. Light blue line elective admissions, and the dark blue line emergency admissions. If you compare the 2 graphs, what we can see is that for elective admissions, the pattern for the 2 groups is pretty similar. Things then get very interesting when we start looking at emergency admissions. If we narrow in on the red boxes, what you can see is that for our prisoner group, there's a very significant drop in emergency admissions in December that is not replicated in the general population. So why is this? I've shown these results to a variety of people, and we've discussed a variety of hypotheses about why this might be happening. And this goes back to the context slide that I mentioned early on, in that it's not just about thinking about the hospital data, it's all the things happening in prison that might explain actually what's going on here. One solution suggested to me was that actually, well, maybe there are physically just less emergencies in December. The person said to me that the regime in prison is softer in December, meaning that people just don't need to go to hospital. Okay, so that was solution 1 suggested to me. Solution 2 was that this is about staffing. There are less staff in December. We know that the prison service, since between 2010 and 2017, there was a drop in around a quarter of operational staff. Numbers are starting to increase slightly now, but there's still this pressure in terms of staffing numbers, and crucially as well, the number of experienced staff too. So that's what we're seeing here. We're seeing a compounded effect in the holiday season of less staff being available to move people to hospital. So it's not that there are less emergencies, it's that there's just less emergencies getting out to hospital. So that's 2 solutions. And if it is one of those 2 solutions, they both have very different implications in terms of lessons that could be learned. If there's something magical happening in the month of December in prisons that means that there are less emergencies, surely there's a case to be made here that this should be happening across the whole year. I don't know the answer to this drop, but I think actually if there's lessons to be learned here that could mean that conditions in prison improve, that is something we should be wanting to happen. So another main finding we talk about in the report is the extraordinary level of missed appointments affecting prisoners. We found that around 40% of prisoners are missing outpatient appointments, and this is around double the rate of outpatient appointments missed in the general population. So in hospital data, we can categorise the reasons that are listed as to why outpatient appointments are missed. And that's what we see here on the screen. So let's discount the bottom category, which is where appointments are cancelled by the health provider, because actually rates are fairly similar between the 2 groups. Where it gets more juicy is when we start looking at the top 2 categories, because it really points to some of the challenges around the sheer delivery of healthcare for people in prison, and ultimately what this means for people living there. So our top category. This is where appointments are cancelled by or on behalf of the prisoner. So in this case, it means the prison is cancelling these appointments in advance. This can happen for a variety of reasons. And a lot of this is to do with how appointments are managed. So you may or may not be aware that if you're a prison, you have to have a certain number of staff to escort people out of the hospital to prison, and you have a set quota of escorts so that you're able to move out per day. There is no publicly available information on how many escorts each prison is set, but anecdotally, people have said to me anything ranging between 2 and 5. So let's say you're in a prison that has an escort quota of 3 people a day. You have a patient that's scheduled to go out for an appointment, but on that day, somebody else is in more urgent need. The first person appointment then ends up being cancelled. So this is one of the reasons we're seeing this slight gap here. The second reason is something slightly more administratively normal. It's that actually, ultimately, sometimes people are moved to different prisons, so appointments have to be cancelled. Sometimes there's court appointments, and sometimes people have just left prison before the appointment takes place. So there's a few things going on there to think about. Our second category is the sheer did not turn up on the day group. So why might that be happening? This is where we go back to thoughts about staffing again. So we know that staffing in prison is challenged. Conditions in prison are obviously challenging as well. And ultimately, and this has been quite widely reported in other areas as well, sometimes there are physically not the staff available to escort people out to hospital, therefore the appointment on the day does not take place. And I should say as well that this also is a problem in prison. So even physically moving somebody from their house block over to healthcare sometimes doesn't happen because there's not the people available to move people around. So in terms of actually sort of sheer results, the last example I want to give to you is how we thought there was a real value in using hospital data to answer specific questions. So you may or may not be aware of the tragic case in December of a newborn baby that died at HMP Bronzefield. That case is still under investigation by various organisations, including the Prison and Probation Ombudsman. But actually, it uncovered a wider point of interest that actually we don't really know much about pregnant women in prison. We don't know how many they are. We don't know how many women are giving birth. We don't know what happens to them. We don't know the outcomes of these births. And crucially, in the case of Bronzefield, there's no firm data about where women are giving birth who are in prison and pregnant. So that's where we thought there was a real potential to use hospital data to look at this in a bit more detail. What we were able to identify in hospital data was 50 women who gave birth in 2017-18 in hospital. But more alarmingly, we were also able to identify a further 6 births that took place outside of hospital. This doesn't necessarily mean all these births took place in a prison cell. They could have taken place en route to hospital too. All we know from the data is that they did not take place in hospital. So this is roughly 1 in 10 births of women in prison is taking place outside a hospital setting. We do not want women in prison to be giving birth in a prison setting. Prisons are not equipped to support the needs of a woman in labour and to safely deliver a baby for a raft of reasons. There is not the staffing, there is not the equipment, there's not the support network, and the list goes on. So we want effectively this to be a never event. So my takeaway message from this particular aspect of the work is the numbers here are not enormous, so surely it shouldn't be beyond the realms of possibility that we can provide safe care for women in prison who are pregnant and go on to give birth. So the report itself, it covers various recommendations. We've got 5 recommendations over 3 areas. So the first is around the need to improve prisoners' access to healthcare. We need to be transparent about how escort numbers are set. We need to know how many escorts each prison is set and also how many are achieved, because that's the only way we can start to look at whether the needs of the population are actually being met. We also need to make better use of hospital data because it's an untapped resource. One of the other things that's covered in the report is some examples of avoidable health outcomes. So, for instance, diabetic ketoacidosis. So if there's people interested in certain areas that might point to perhaps care that's provided in prison, hospital data can provide effectively shine a light on that. So in our data, we're able to identify over 50 cases of diabetic ketoacidosis, which raises questions about long-term condition management inside prison. The main report itself, it also covers a raft of areas that we're not covering in this presentation today. So more information on use of A&E services. We also have as well coverage on chronic conditions, and information as well on how uses of services by prisoners compares to the general population. So the takeaway message from that aspect of the work is that actually prisoners are using services less than we might expect if we compare to an age-sex standardised population comparator group. So I've slightly rattled through my slides, but if anyone is interested in looking at the report in full, the web link is there, and please contact me if you have any questions, and I'll be happy to help. Thank you very much.
Thanks, Miranda, that's brilliant. And there are copies of the report available on the tables for people to take away as well. So Miranda's given us a kind of real tour de force, I think, on some of the issues facing one particularly challenged group in society. But prisoners are not the only group that face challenges in accessing healthcare services. So our other panellists are going to talk to us more about some other groups that are vulnerable, are neglected, are treated as hard to reach. So I'm going to ask our panellists in turn to introduce themselves and to talk a bit about the areas that they're particularly interested in, starting with Andy.
Thank you. So I'm Andy Bell. I work at Centre for Mental Health. Hopefully you know about us. If you don't, have a look on our website. We're an independent charity, and our work is about reducing mental health inequalities through research and development. Just a quick word on the mental health aspects of the prison population. We know that very, very large numbers of prisoners throughout their lives have had very poor mental health and often very unhelpful contact with both child and adolescent and adult mental health services, often making contact but never quite being accepted or found a place. We also know that when people are in prison, we have extraordinary long rates for transfers to mental health hospital. Often something that would happen in hours in the community takes well over 14 days, and that's the aspirational target at the moment. And we also know that when people leave prison, even if they've been seeing mental health services, a piece of work we did recently with 63 prisoners supporting them into employment, only 9 who'd been seen by a specialist team within prison unwell enough to do that, only 9 were accepted on community mental health team caseloads. So there's a lot we need to do, but on a more positive note, one of the really extraordinary achievements of the last 10 years of health policy, picking up Nigel's question from yesterday, is development of liaison and diversion teams in police stations and courts around the country. We're nearly there in terms of full coverage. It's an extraordinary achievement that NHS England have pulled off, and they deserve an enormous amount of credit for that. So there is hope. So in terms of mental health inequality, some of these things will be very well known to you, but it's important to restate them. We know that 1 in 4 of us have a mental health problem at any one time. We've all heard that 1,000 times, but that figure masks an enormous amount of inequality. We know children from the poorest households, the poorest quarter of households, are 4 times more likely to have a mental health problem at the age of 11 when they're finishing primary school than children from the wealthiest quarter of households. We know that there are very much higher levels of poor mental health among people with learning disabilities and autism, something like 3 or 4 times more likely. At the other age of the spectrum of age to children, we know that people living over the age of 85 have roughly twice the risk of poor mental health as younger people in the population. And we know there are very specific risks of poor mental health to people from LGBT plus backgrounds, black and minority ethnic communities, many different inequalities in mental health. That are really quite extraordinarily stark differences. And crucially, that is not because of equality of those groups of people. And often efforts to explain mental health inequalities have looked at what it is about that group of people that puts them at greater risk. What we really need to understand, and we've been looking for the last 18 months at what causes inequalities in mental health and what some of the solutions might be, is it's the things that happen to you that are coincidental to having that identity that put you at greater risk. So bullying is a very big risk, isolation is a big risk, experiencing violence and abuse, being poor, being disadvantaged, and being discriminated against in society in general. Those are the things that are inflating the risk of some groups of people to experience poor mental health. But crucially, what we know too is that the same groups of people often get poorer access to healthcare. And yes, we are incredibly lucky to have a national health service, which means that many of the inequalities in terms of access to healthcare that are experienced in other countries are not the case here. We don't, thankfully, have to be able to pay for our treatment, but we do see numerous other barriers that people fall through that stop them getting access to the support that they need. And we also see poorer outcomes for some groups of people. So if you're from an African and Caribbean community, you are more likely to experience psychosis, but you're also more likely, again, to be detained under the Mental Health Act. And once you're detained under the Mental Health Act, you're twice as likely again, when you leave hospital, to be placed on a community treatment order, which is something that means when you leave hospital, you can still be subject to compulsory powers, even though you're living at home. So we know these run right the way through the system, and we know there are solutions to this, and that's what we really need to be talking about. You may have noticed today that one of the headlines that wasn't about coronavirus was about universal credit, and some really important research showing that the introduction of universal credit has come at the same time as an increase in depression cases among people in receipt of benefits. We need to understand that this is just as much the territory of health policy as the NHS and what's going on in health and social care. We need to look at what is happening in our criminal justice system. We need to look at across the whole piece. We need to be thinking about school exclusions. You may know there was a pledge in the government's manifesto to increase the use of exclusions, to build more prison places. These are things that will be toxic to mental health, and we need as a health community to think about how we can address those. There's probably loads more I can and would like to say, but I should probably also let other people speak.
Thanks, Andy. Turning to Andrew.
Thank you. I'm Andrew Hayward. I'm the director of the UCL Institute of Epidemiology and Healthcare, and I'm also co-director of the UCL Collaborative Centre for Inclusion Health. One of the things that we did recently was publish a meta-analysis in The Lancet of the excess mortality rates in homeless people, drug users, prisoners and sex workers, who we thought were highly overlapping groups. And what we found there was a 10-fold higher rate of mortality in those groups than the general population. And this included increased disease rates across all categories of disease. Yet despite this extraordinary level of need, these groups are virtually invisible within our routine health data. These groups are often labelled as hard to reach or inappropriately using health services. But in fact, the truth is it's our health services that are hard to reach and are inappropriately treating socially excluded groups. Negative and stigmatizing experiences of using the healthcare service are the norm, and they serve to push away those most in need of our care from our services. I think it's easy to lay the blame outside the NHS and at broader societal factors, but actually the NHS can do an extraordinary amount to improve the health of socially excluded groups. The Inclusion Health movement is a research, service and policy agenda that aims to prevent and redress the extreme health inequalities suffered by socially excluded groups. One of the things that we did recently was to conduct a review, again published in The Lancet, about what works in inclusion health. We wanted to find what evidence-based interventions there were that health services could and should be doing and investing in. And I'll just run through a few of those. So, pharmacological treatment of infections works, of HIV, TB, hepatitis C, but if you want it to work, you need to accompany it by enhanced case management to make sure that there's good levels of adherence. So, for example, we recently published a randomized controlled trial, again in The Lancet, of an intervention for socially excluded tuberculosis patients with homelessness, addiction, prison histories, mental health problems, where we use smartphone-enabled video-observed therapy instead of face-to-face directly observed therapy. And we found it more effective, more acceptable, and cheaper than face-to-face directly observed therapy. Yet we struggle to get this model of care commissioned across the NHS. We'll shortly publish a paper that shows if you take patients with tuberculosis with no recourse to public funds and you house them in the Olalo Centre, we can double the rate of treatment completion and reduce mortality rates. Other pharmacological treatments work, long-acting antipsychotics work, opiate substitution works, supervised injecting works. If those don't work, naloxone works. Cognitive behavioral therapy and psychosocial interventions work. Case management, where we're integrating the health and social care to provide a coordinated, holistic package, works. Outreach works. For example, we pioneered the Find and Treat street outreach program, which screens up to 10,000 homeless people and drug users for tuberculosis and hepatitis C and provides vaccination and case management. Works, yet the model is only available within London. Interventions such as connecting people to housing work, yet how seriously are we really taking our duties under the new Homelessness Reduction Act? Linking people to employment and volunteering opportunities work. And finally, and very importantly, I think the putting service users at the heart of service design and as part of service delivery works. But how often are we doing that? I think it's really behoves the NHS to start to take an evidence-based approach to the management of socially excluded groups, and I would really call on all of you here to help in that. Thank you.
Fantastic, thank you. You've got a few slides for us.
That's right, thank you.
You have two heads.
Tonight, when we get into our beds, there'll be at least 10,000 people huddled up on cardboard in sleeping bags in the rain and the wind. And this is a shameful fact. And there'll be tens of thousands more in inappropriate and insecure accommodation. Homelessness is rising and the homeless are sick. Every one of those huddled up people that we scurry past on the streets as we rush into our supermarkets, our warm cars, our restaurants, every one of those sits there with a death sentence on their head. The average age of death for a homeless person is 42, a shameful fact and surely a public health emergency. What are the barriers? Why are we not doing more? Why aren't we all shouting out about this? We're looking at the barriers from the practitioner's point of view and from the patient's point of view. Patients are stigmatised. We would all deny that, but there is robust evidence that homeless patients are stigmatised. The medical reductionist model, this is where we focus simply on the problem that we're presented with and don't have the time or the resources to look at the bigger picture or deal with it. Patients are turned away from GP registration. We would all deny that happens, but there is good evidence for it. NHS charging regulations. Just last week in my own A&E resus department, we watched a 1-year-old child die of TB meningitis. The parents, who were asylum seekers, had been too frightened to take their child to the doctor before for fear of charges or deportation. We witnessed their grief and the death of a 1-year-old simply there because of a fear that does not need to exist. And finally, education, leadership, changes, doing more, health inequalities, teaching, not just in medical schools or colleges of midwifery, but right back into school, for children to learn that at present in England there is a 19-year difference in death rates between the richest person and the poorest person, and that we all need to stand up and fight these terrible injustices. The patient barriers, why are these silent, these 10,000 people silent? What other patient group would sit there and put up with these terrible injustices of sleeping on a sleeping bag on the street, facing a very premature death from a largely reversible or treatable cause? It is unacceptable. I think the easiest thing is that they've lost all confidence and ability to speak for themselves. But of course, language comes into it, literacy, fear of stigmatization. They are often feeling ashamed, and yet they should not, of their situation. What can we do about this? Every one of us in this room and beyond must stand up and be that voice for the homeless who have no voice of their own. And we must stand up and make sure that these terrible social and health injustices are banished forevermore. We have to do this across primary care and across secondary care, and across finding ways of supporting people on discharge from hospital, and education and leadership, and every one of us can do those things. In our own hospital, we have banned discharging the homeless back to the streets without some secure accommodation, and this should be the rule across every NHS trust in England. We would never discharge any other vulnerable person back to a vulnerable situation. It's a classic example of safeguarding. And to discharge a homeless person who's presented back to the streets is, from now on, should be completely banned. So every one of us needs to stand up and do more. The numbers are still rising. The figures this morning, which we hoped would show a fall, have not transpired. The figures have risen again, and it's up to us to support these people and get them out of these terrible situations. Thank you.
Thank you, Pip. That was incredibly powerful. So we're going to move to questions now, and we'll take a mixture of questions from the floor and questions on Slido, if you want to be using Slido. But just to kick off, and I've been trying quite hard, you've all tried hard, to frame what we're talking about today as not about problems for people who are hard to reach, but about services which are hard to reach. Why do you think we find it so difficult to take that framing? Why do we keep in the service persisting in talking about and framing it as hard to reach groups? What is it that gets in the way of that mindset shift? Anybody want to?
Well, I mean, I would say that we're very tied to our traditional models of healthcare delivery. We're very tied to buildings-based services. We're very tied to silos of specialty. So, you know, a lot of these people will have multiple appointments. You know, it's the respiratory physician on one day, it's the liver physician on the other day, it's the mental health team another day, the addiction team another day, and we're not really doing anything to join that up and make that experience and access to healthcare easier.
One of the interesting things that's come out of our work, particularly with young people in some of the most marginalised communities in London and Birmingham, is hearing that actually they have an enormous amount of contact with public agencies. And for them, they all begin to merge into one. And so they have terrible experiences with school, where they're treated as bad and naughty from day one. They're terrified, or their parents are terrified of social services. Of having their babies taken away when they're young and then losing them or getting into trouble when they're at school. Difficult experiences with the police, particularly for teenage boys. And formal health services that feel like they're part of that system, are not trusted. And so very often, particularly young people will feel that if they approach a GP or let alone a mental health service, which is extremely unlikely, that will get straight back to some of those other places. And so there isn't that trust and belief. And I think that's a really important thing that we have to think about. How can we move away from that sense that all public services are experienced much the same?
Thoughts?
Just that these are not a hard-to-reach group. These people are here with us. We see them every day of our lives, not only on the streets, but I work in hospital, in general practice. They are not hard to reach. They come, they're sick, they're 5 times more likely to attend hospital. We are ideally placed to be there to help.
And I think that comment that's there on the slider that people can see at the top of the screen, that thinking about our language and shifting to seldom heard rather than hard to reach is probably a very powerful shift. I think there's another good question there on Slido from Helen McKenna, which is about the opportunities for use of digital and telemedicine. Obviously, Helen's framed it in the context of prisoners, but I suspect it might be something that is useful for other groups that we're talking about as well. But Miranda, do you want to pick up on that and the opportunities there?
Yeah, I know one of Andrew's colleagues is doing some sterling work looking at use of telemedicine services to improve healthcare, the way that healthcare is provided for people in prison. So I'll let him talk briefly about that, but just to say about the prison context. So prison health services in prison, they're commissioned predominantly by the NHS, but it's not a natural environment for the NHS to operate. It's effectively, they're operating within the prison system. So there's sometimes this pull or this tug between the way that the healthcare operates in the prison and the way that the prison system operates. And I think from discussions with Chantel, Andrew's colleague, this is something that actually plays out in the provision and use of telemedicine services as well. We found in our work that figures currently for use of telemedicine services in prison are extraordinarily low. So there is an opportunity there, most definitely, to think about that as a way to improve access to healthcare for prisoners. But I would caveat though with the point that I made in the talk, that even getting people to healthcare appointments within the prison that they're living in can be a challenge as well. But I don't know if you want to talk any more about Chantel's piece.
Yeah, I mean, it's very interesting. One of the few advantages of the extraordinary number of prisoners who are in the United States is that they have developed very good quality telemedicine services within prisons, and often because they're able to do it at scale and they're able to do it through single organizational units. I think there's a big challenge in introducing telemedicine in that brokering the relationship between the prison and the trust, and dealing with all of the sort of politics and the information governance issues. And in fact, for Chantal, that's taken the first year of her fellowship to sort that out before we can get our first telemedicine case. But it's doable. I think there's other big opportunities for digital technologies. I already mentioned, the smartphone thing for case management of patients. But I think often what we're talking about in inclusion health is the need to integrate between professional groups, and information and communication technologies really should be being used more to allow that interprofessional discussions, and bringing the client into those discussions as well. So I think lots of opportunities.
Thank you. Pippa, Randy, anything you'd like to add?
One of the perfectly obvious statements we need to make here is that prisoners are among one of the most digitally excluded people in our society.
Yep.
And there are perfectly logical reasons for that. But I think it is important to understand we sometimes receive letters by Royal Mail from prisoners talking about their mental health, desperately wanting to know where they can get help and support. And obviously there are ways of adapting digital technology in that context, but very often we have to understand the particular levels of exclusion that will affect them with. I think the other thing is the thing that we know particularly has an effect on prisoners' mental health. Obviously, it's partly about the conditions in prison, but it's often about fear of what's going to happen afterwards. So not knowing where you're going to live, not knowing if you're ever going to have any money coming in, worrying that your children are being taken away, particularly for women prisoners again. These are really quite fundamental things, and we need to get the basics right first with people in the criminal justice system. We need to understand the very, very simple things in life that are putting their health at very, very severe risk, and in the worst cases leading to the roughly 90 a year losses of life through suicide in prison.
Thanks, Andy. Any questions from the floor? Fazana?
Thanks for, can you hear me? Yeah, thanks for a really good talk. very close to my heart. Just wanted to make one point and one question. As a GP, when my patients go into prison, to remember that we're still their registered GP. There are patients. I've lost 2 patients, one age 36. We know that interface is always difficult. Discharge from prison. Actually, on this occasion, I had got some information that this patient was coming to me within 48 hours, but sadly died before then because of drug withdrawal. We didn't even know what drugs he was on. The second case was a 45-year-old who preferred prison because he liked the routine, and on discharge he had no lighting in his house, nothing at all. He died at the age of 43 of alcoholic cardiomyopathy. So my question is, as a system, there's interoperability, but what about, there's prison doctors, what about more shared? Primary care networks seem to, again, be a place where we could involve our prisons. It's not just about community care. We have some more about that. The DESers at the moment don't reach these people at all. They're the people that I want to work with.
Great question, and it links actually, I think, to the one that's on the top of the screen there about the transfer of health records between prisons and GPs as well. So, Pippa, is there anything you'd like to pick up on that?
I'll let the others answer for the prisoners, but just say it's the same problem for the homeless, discharged from hospital, often antibiotics or something, but they've nowhere to keep them. We had someone discharged who had drugs they had to keep in the fridge. I mean, they could hardly walk around with the fridge on their backs. It was ridiculous. The information for follow-up arrangements is just sent into a black hole. No follow-up appointment is ever, they have no address. They're NFA. So, yes, it's a huge problem, follow-up and transfer of information.
So what could we do about that? What could we do about that in the prison setting?
Well, I mean, I think
in the other setting?
there are positive movements towards improving the electronic health records for primary care within prisons, with them moving to a unified system of System 1, which will allow transfer of information into general practice much more seamlessly. So that's a very positive thing.
Any thoughts, Brian?
Yeah, I mean, there's an inordinate amount of work going on to address some of the issues that have been raised here. So GP to GP registration is currently in progress, but much like within changes to the NHS as a whole, all of this takes an extraordinary amount of time. There's 117 prisons and young offender institutions across England and Wales, so this doesn't happen all in one go. There's a pattern of how this moves across all of the prisons. So as well as GP to GP registration, there's also PDS coming in, so patient demographic services, which will make it easier to actually, when patients go into hospital, to actually pull up their records as well. So hopefully, in the future, we won't be still having cases of looking at paper records, and there'll be a bit more sort of shared continuity of care.
So it does remind me of one of my own experiences commissioning prison healthcare, and I remember, so this is when I worked in Medway, and I had a long conversation with the then governor of Rochester Prison, which was at that time was a Young Offenders Institute, about the difficulties that the boys in his custody had in registering with primary care when they were released. So we had a long conversation about what we could do to build connections with local GPs and so on. And then I said, they do come from around here, don't they? And he said, oh no, most of them are from London. Okay, that's part of the challenge that we have in the NHS with our fragmented structure and actually helping people connect with services.
Can I? So a couple of points on that. One of which is imprisoning fewer people would help. And we really need to keep that voice of health in some of those debates, which may seem very far from what we're talking about. The other thing is there are some really effective through-the-gates type services, often peer-based, which provide mentoring for people both before they leave prison and working with them when they leave. We know for many people the time of prison relief is a time of crisis. It really is. It may seem strange. You might think, well, that's great. They're leaving prison. Hooray. For many people, they're terrified of it, and it is a really challenging experience. So mentoring services and peer-based services doesn't even need professionals particularly to be involved. And that, again, is often where we've got really exciting things happening in the voluntary and community sector that with the right support might help people make those transitions more successfully.
Thank you.
And there's some other organisations as well that are doing great work in terms of employment opportunities. So Timpson's, for instance, springs to mind, that are doing great work helping people, have employment to move into when they leave prison.
Thanks, Mary. So we'll take a couple of questions from the floor. I could see Andrea had a question, and there's a lady about sort of middle back. Yeah, so we'll take a couple of questions.
Colleague on my table also has as well.
Take three.
Just three quick points. The first is around the importance of joining the dots again. And one of the things which has sort of been touched upon, but I think we should bring out a little bit more, is those people who have been in care up until the age of 16 or 18, who come into both the homelessness and the prison kind of population. And one of the things which just distresses me enormously is that we think young people who have had those experiences are going to be able to stand on their own 2 feet at the age of 16 and 18, and then guess what? So kind of thinking about how we make that link and think about that from a policy and a service perspective. The second thing is that we can learn from some of the good things that are happening. And I mean, Pippa, I thought your presentation on homelessness was just absolutely superb. So thank you. But there are some good places that are doing some fantastic outreach work, particularly nurse-led units. And I had the real pleasure of meeting Sue Temple in last year. She is doing incredible work with her team. So I think we should really be looking for those golden nuggets and seeing how the things that she's been doing over the last 20 years can be shared. And the final thing is, this has been a great session, and particularly with all due respect to the gentleman, but Miranda and Pippa, I did think that your presentations were fabulous. But wouldn't it have been good if we'd had the testimony of people who are experiencing this, their voices in this room as well? And I just leave that thought with you.
Thanks, Andrea. I had the opportunity to hear Len Sisse, the poet and care leaver, speak last weekend. And if any of you haven't heard him, get the chance to, I thoroughly recommend it. It's the most incredibly powerful presentation. Should we take the other question on that table as well and then move to the back?
Hi, I'm Catherine Scott. I'm the Director of Policy at the British Psychological Society. One of the things we're looking at is how we kind of develop the psychological professions for the future. And I think a lot of what we're talking about here in terms of stigma, support, different models of care is a workforce question. And I think it'd be great if the panel could kind of reflect on what different roles might be needed to kind of respond to some of these, I was going to say reach the vulnerable, but you know what I mean. In terms of kind of both in forensic settings. So, we have psychologists who work in forensic settings in prisons, and also kind of what the content of the training and how that might be different. And if there's people from Health Education England in the room, it might be something for them to reflect on as well.
Thanks, Catherine. So we'll take the lady at the back and then come back to the panellists. Oh, all right. Lady in the middle there. We'll come back to you afterwards.
Hi, so I'm Suze Ebeland from the University of Oxford, and this is not my field, but as I understand it, there's pretty good evidence that the housing first model works. And instead of the housing first model, where you give people a house, it's like it sounds, and then you help them to sort out the other problems they may have, we don't use that. We used a stepped approach, where at every point people have to prove that they are behaving well. That seems punitive, and it also feels a lot like we're still using what I hoped would be an outdated model of the deserving poor. I'd be really interested in your comments.
Thank you. So quite a few points there. Our attitudes to people who are seldom heard, or Andrea's point about actually not having the voice in the room, the role that different roles can play, the role of housing, the role of outreach. Would you like to pick up on any of those?
Well, I'd quite like to pick up on the housing first. We recently did a tour of homelessness services across North America in Los Angeles and Pittsburgh and Vancouver. And there's a lot of talk about housing first, and particularly in Los Angeles, where they've got 50,000 people living on the street. They've increased their local taxes specifically to help to pay for housing first models. But the capacity of that is just so woefully short of what is needed. And also, often what is happening is you're plucking people out of their existing community groups and putting them into an isolated flat somewhere. And sure, Housing First is supposed to come with all of this professional backup and linking to services, but too often it doesn't, and people just knock straight back out of the system. So I think we need to be careful about thinking of that as a panacea. I'm an advocate for it, but I think we need to do other things alongside that hugely.
Yeah, no, to address the point about housing, there are a number of inspection reports last year and also independent monitoring board reports last year that picked up on people who were leaving prison being given a tent. So I think that kind of points to the challenges of where we are around ensuring that people who leave prison have settled accommodation. So, you know, much like some of the challenges we found in our work that people say, oh, there's no data, it's really hard to collect data, you know, we really just don't know what happens to people. Actually, we know that they're not going into settled accommodation. And I think, you know, when I talked about the slides of the before, during and after prison, ultimately what happens is we get this link back to the beginning again. So if people leave prison and they don't have settled accommodation, there's a possibility that they're just going to go back into that loop of moving into prison again. So.
Pippa, Andy, any thoughts particularly about the points made about outreach and the role of different professionals can play?
Well, just first, you're absolutely right. And I did mean to acknowledge in my talk, and I'm sorry I forgot, that there are some amazing pockets of fantastic work. I think there was in my slide it said that's the thing, we're not joining up and we're not learning from each other. But yes, there are some great projects out there for the homeless. Housing First, yes, totally. Absolutely, well, you heard it from the expert there, but yes, we would absolutely agree with you. Housing First. You know, even my own MP, who's trying to help the homeless in our city, says, well, you know, let's help them get jobs. And we try to explain to him that when you are sleeping rough, you know, it's very difficult to get up and go for an interview and look good and produce a CV. So absolutely Housing First, then attend to with the caveats we had, then attend to all the other things that they're suffering.
I mean, I think the point about teams, really, and the workforce, I think, is really important here, because, you know, integration doesn't happen at the sort of management level. It does a bit, but it's really about interdisciplinary teams and multi-professional teams, and actually increasingly thinking about people with multi-professional skills. So, you know, why can't we give train nurses to be dual trained in nursing and social work, for example, so that they can meet the needs of these groups more effectively. And so I think we really do need to invest in these specialist teams, but we also need to really invest in upskilling the entire NHS workforce in understanding the drivers of this and the challenges that people face, and making them well placed to be able to link people into other services. So I think there's a big role there for Health Education England. I'm fortunate to have a research fellow who's focusing on how to develop that into professional education at the moment.
Great, thank you. Andy?
I can't help saying on Housing First, we're looking at it in the moment in the context of mental health. The really good thing about it, and with the caveats about it's not the panacea to all the world's ills, nothing is, it's a rights-based approach to supporting people with housing, and that's the crucial thing. It's about getting into a tenancy, a place of your own. You need to do it in the right way, not cut corners, but done in the right way. It does appear to be a really important way forward that we need to think about. In terms of the workforce, I think I've already talked about peer support and mentoring. That's an incredibly important part of the workforce. And what we know is that having peers within mental health services, for example, starts to change the conversations. You don't have conversations about people without them being present in the room, without them being part of the conversation, because they're part of the workforce. The other thing I really want to add, and this is so important, is that one of the most important forms of health workers we've got is people that advise with welfare rights, with housing, with basic things. We know that having welfare rights workers within primary care, within psychological therapy services, mental health services, They reduce the chances of people going into hospital and spending 2 or 3 months there and finding they've got no house to go back to. They can stop people being admitted to hospital in the first place by looking at making sure people are maximising their incomes and not getting into trouble with their council tax, which you can go for prison for not paying. So really, really simple things that may seem like, again, they're not part of health, but they most definitely are.
Thank you. Can we take the microphone to the lady at the back?
Oh, thank you very much. So I just had a couple of reflections based on things the panel was saying, that, and it comes up through our own work, which is mostly with people at the older end of the age spectrum who are severely excluded. But I think there's a view that perhaps we don't look at people under the age of 65, and in these contexts we emphatically do. I think there's two things. I think firstly we need to be really honest about resources and also professionals' own sense of powerlessness in the face of some of these things. And I think that's an unacknowledged area here that certainly comes up for us. That actually it takes time, as Andy says, to build a report. Lots of people are very much in touch with services and many descriptions: social services, criminal justice system, education, health services. But in each one of those places, it's easier to brush them off and move them onwards, because actually to take the time to build the report, to gain the trust, to open the box and unpack all of the issues inside it, takes a lot of time, it takes a lot of resources, and actually a lot of fear on the part of professionals anyway, that what could they do? Because it would take such a multi-agency approach, it would take so much time, it would take so much resource, and they just don't have that, or they don't have access to that. So it's easier never to open the box, basically. I think that comes up quite strongly, and we need to be honest about that and encourage staff to talk about that. The other issue I think perhaps we should reflect on is also, even within the context of this conversation, we're slightly stereotyping people. We have a feeling that we know what somebody, like a prisoner, a person who's street homeless, that somebody's living with severe and enduring mental health conditions, we kind of know what they're going to look like when they come into a service, and we're going to recognize that. And sometimes, obviously, we do, because it's, you know, they perhaps so far that they've so fallen off the edge of the mainstream that it is quite clear. But often we don't. And we see this a lot with older people, because people, it's what we call the Miss Marple effect in the office. People's stereotype of older people is white, female, frail. They don't think of older people in all of these other contexts. So often older people get brushed under the carpet, and those issues aren't recognized because nobody expects a homeless older person. They don't expect an older sex worker. They don't expect to see an older drug addict. So they just don't ask that question. Nobody expects older women to be living with domestic violence. So I think we also need to be careful. It's not just about not stereotyping people as hard to reach or seldom heard, but actually being really clear in our own minds that we don't necessarily know what these people look like. And we have to be open-minded to that, to every single person that walks through the door.
Some great points. And I think the first point that you make, the first question you raise about funding and use of resources and the role of professionals has some links to the second question that we can see on the screen there about the role of commissioners and whether commissioners are prepared to look at different funding models and to coordinate resources in different ways. So perhaps people could reflect on the comments made at the back and also pick up that question about the commissioner's role.
I mean, I think the point about shortage of resources is well made, and in fact it's substantially worse than you're making out in terms of the services for these groups of people have been systematically disinvested in much more quickly than other parts of the service. I don't know why that is. I suspect it's because they have no political voice. But I would say, you know, we urgently need to redress those imbalances, all the drug treatment services that have been shrunk and farmed out to the lowest bidder on very short-term contracts is a huge problem with how you maintain these services. And the same goes for specialist homeless services as well. And I don't think we really sit and bother to count the cost of that. You know, the cost in terms of avoidable hospital admissions, long, complicated, expensive admissions, huge amounts of A&E usage. We're not costing the cost of inaction, let alone the human consequences of that.
Thank you. Andy, you look like you want to comment?
Sure, I can always find something to say, can't I? I think in terms of at the individual level, I think what's really interesting when we look at the mental health of people in later life, very often we find there's a fatalism. There's an assumption among health professionals, well, yes, of course you're not got good mental health at the moment because you're old and you're experiencing isolation and less physical mobility, and taking this as inevitable. And I think it's one of the dangers of when we start talking about the inverse care law, that we almost regard it as being something which is inviolable and can't change. And I think sometimes it's being open to having these conversations and identifying a need that someone's got, or helping someone to talk about a need they've got. Very often when people go and see a health professional, they might go in with one thing, but really be desperate to talk about another thing. And that other thing is often mental health. But again, in some places you have this, you can talk about one thing per GP appointment rule, which immediately takes away any opportunity to have that conversation. At a commissioning level, we've recently had a look at integrated care systems. If integrated care means anything, it's got to be an opportunity to start to bring in services for some of the most marginalised and discriminated against groups of people we talked about today. You could do that at a larger scale than you can in a local area. So I think there's a real challenge there for every integrated care system, not to just look at one or two inequalities or to pick or choose, but look at the whole lot and understand what are we doing around these whole range of issues for people that we haven't served terribly well. And then at the very, very local level, I think it's really interesting that in some areas, primary care services are now beginning to bring in psychologists, for example, or other mental health professionals to work at a very, very local level. So again, there's an opportunity with all the redisorganisation going on to think about how we can take a moment to do something a little bit different in all of those different places.
Thank you. Miranda, any comments?
Yeah, sure. I think I agree with both of the points that were raised there. So just some kind of slight musings in response. So about kind of things that we might not expect about prison, people in prison, for instance. So when I was discussing, there's a chapter in the report about older prisoners. So in prison, an older person is normally considered from the age of 50 plus. So we had quite a long debate and there was a real need to actually understand why in prison you would be considered older at 50, whereas in the general population we would not be thinking about people being older at 50. And in terms of the staffing point, I think a real challenge in prison, it's not just about health staffing, it's also about prison staff as well. And the reduction in prison staff and the people that are coming in, which is obviously very much needed, but there has been a loss of experience. And the point made by the lady about the fact that it takes time and experience to develop relationships with people, I think that's where the experience of prison staff in particular is very important.
Thank you.
Just about the resources thing, which the Royal College of Physicians recently surveyed all its members and fellows about doing more for health inequalities, and had a resounding result of everyone wanting to do more. And then the barriers why were, of course, time and funding. But the third barrier to doing more, they said, was lack of leadership and championship. And I think this is a big thing that I found when, I sort of stood up and made a noise about it in my hospital. Other people followed. And I think if everyone in this room and everyone in every hospital, in every practice stands up and makes a noise and says, let's do more, it does actually raise up a groundswell of, public support. And even little things like bringing in clean clothes for our patients. Thank you. Even, I think every one of us,
yeah, I think that one's right.
Can do more. And even if it's just a small thing like bringing in clean clothes for our patients, which are avidly taken up in casualty, to doing major sort of policy changes, then we've all got a role to play, every one of us.
Thanks, Vivian. More questions from the floor. I could see that Becky Rosen had one, so we'll go to Becky, Richard, Naomi.
I'm curious to know what the panel think about the idea of intractability of problems. And I asked that in response to the previous question about people with ongoing complex needs. So in a past period of time when we were running an integrated care pioneer, we were lucky enough to have the resources available to really, really dig into the causes that people who were experiencing a variety of vulnerabilities, high use of services, and mental health problems, what was underlying them. And we did have the resources to really try and put things in place, working with the criminal justice system, with the probation service, etc. And we made some progress with some people, but we had some people who, in the end, we felt were intractably problematic. Despite all of our efforts, we could not change the course of their repeated breakdowns in whatever we'd set up. And I just wonder whether your general view is you never give up and you just have to keep going, or whether you get to a point where you think, actually, we need something for people who are just too difficult. And there's some way you need to respond to the too difficult category that doesn't leave them with nothing, but put some things in place.
Thanks, Becky. Richard?
So Richard Bomer from the Nuffield Trust. We've talked about the impact of employment on health and ill health, and we've also mentioned a number of times the observation that oftentimes the hospital is the largest employer in any given community. Are you aware of experiments of hospitals using their status as a large employer and a source of jobs as an actual intervention in their community? I've heard talk of it, but I know nothing about it.
Fantastic question. And a final one from Naomi before I ask the panel to respond.
Naomi Fulop, UCL. I just wanted to raise the issue of social care, and specifically in prisons. Under the 2014 Care Act, people might be aware that local authorities have responsibility to assess and provide social care for people in prisons. And we're just starting to do some research on this. Local authorities are approaching it in different ways, and we've become aware of a couple of prisons in Wales and 3 in London who are approaching it in quite an innovative way and providing training for prisoners to provide aspects of social care to other prisoners. Watch this space in terms of what we find out.
Thank you for that. So some questions about, are there really some intractable problems? And are there some creative solutions in the way in which actually the NHS as an employer and the NHS as a key institution in its community can support the groups that we're talking about today?
So to address the point about intractability, I think, and it kind of links to a point that was raised on Slido here, I think by the time that we're looking at people who are in prison, this is the end of a long path of failure at multiple points. And that's why sometimes potentially it can feel like for some people things are intractable. I don't want to be entirely negative though, so I'm going to use an example here of where you can have really good service provision to help people, and I think the maternity pathway in prison is one example. So at HMP Low Newton, they have introduced new maternity provision pathway where there's dedicated time for a midwife to spend at the location providing pet care to people. So I don't think we should ever be giving up, but I can see why actually that can feel like the case at times.
Until a few...
Is it on? Yep.
Yeah. Until a few years ago, I would say nobody's beyond help, but with my idealism. But we do have a few homeless, just a very few, 3 or 4, who say they would rather sleep rough. So I don't like the word intractable, but I would say as long as every time they come in, we let them know we're there for them. They can have hot a cup of tea, clean clothes. They can have the list. Every town, every city in England will have hot meals provided every day by one charity or another. Amazing stuff going on. So as long as they know the support's there, as long as we keep offering and keep offering. The Homeless Reduction Act we touched on was a major step forward. You probably know and should have been the sort of saviour to all homelessness. 18 months ago, the government mandated that all homeless people should be registered, and those at risk of homelessness in the next 56 days, and referred to the local housing authority. And we thought this might solve homelessness. Unfortunately, a lot of trusts are, and presumably prisons, I'm not sure, are failing to comply due to lack of training, resources, even knowledge. I mean, it seems to me a lot of people don't even know that it's the law now that they should be referring, and this is shocking, really. And we hope very much that the Department of Health is reviewing it 1 year on, or they have reviewed it, and we haven't seen the results yet of compliance. But this should be our chance to at least make sure every person eligible for housing is known to the local housing authority. Is a big step forward.
Thank you.
Yeah, I mean, intractability is, I think, partly our own fault. We intervene far too late. We should be providing much more services for troubled children, people being excluded, people at the start of their drug careers, and whereas we tend to leave it until people have got into a real crisis and have developed chronic diseases that are hard to put right. But I don't agree with the concept of intractability. We certainly see some people who you would think that you can't help. So, for example, there's a homeless person in London who was getting about 30 or 40 admissions a year, and everybody was thinking, this is an intractable problem, how are we going to solve it? The thing that solved that was really peer involvement, getting somebody over a long period of time to form a relationship with this person, understand their needs, help to make them think about attending more routine services and things, and that transformed that into a few admissions per year. So people working in the sector do have to get used to the heartbreak of seeing a lot of their clients die. But I think, you know, the saying that we should never give up on anybody is really true here.
Yeah, I mean, I think sometimes we have to acknowledge professionals don't have all the answers, or formal services don't have all the answers, and there may be other ways, particularly where you've got co-designed services, co-produced services, services led by the people who they are supposed to be for, rather than by people who are not. And so we know there are opportunities there. We see some really interesting examples of co-produced projects, such as those led by MAC UK in different parts of London, but there are plenty more. We can show you plenty of those. In terms of using the NHS as an anchor institution and the employer, I think it's about 20 years ago, South West London and St George's Trust, not too far from here, had a scheme called a user employment program, and it was a very simple idea, which was to have a target to increase the number of people using their service who would then come and work in it. And what they found is that being in employment in the trust was actually incredibly good for the trust, because they had people who'd used their services who were then working for them, helping other people. But also it was part of the road to recovery for many people. The assumption used to be you get someone better from a mental health problem and then you find them a job. That doesn't work, it's disastrous. So actually supporting people into work, becoming part of the organisation, or indeed being supported to work in other places, actually help people to enjoy better mental health for the longer term as well. So there are absolutely things that all health services can do as anchor institutions in their local areas.
Thanks, Andy. And I think that's a great note for us to finish on. I was really struck by a couple of things that Andrew and Pippa said. I think what we've heard today from our panel, and indeed from the contributions from the floor, does show that we have got people who will lead and champion these issues, and champion these issues. And we've got people who actually will count the cost of inaction and will say, actually, we need to do something about this. We need to serve the people of this country better. We need to serve the taxpayers better through the investments that we make, and we need to get better outcomes for everybody in society, and not just those who find it easy to access services. So thank you all. We're going to break now for coffee, just in the room opposite. Thank you.
Okay, if I can ask you to resume your seats and we'll go into the final session. When this session was being devised, I don't think we'd anticipated that Matt Hancock was going to answer the question yesterday. How far are we willing to go? Well, apparently no variation at all. We're going to have the same everywhere, but I'll leave that to our commissioning colleagues to have that interesting discussion with him over the coming months. There's always been variation from time immemorial. In the Greeks and the Romans, there was variation. The first time it was probably properly documented was probably Alison Glover, which is with all respect to anybody who ever mentioned some variation or identified it before the 1830s. And he, as you may know, it's very famous, pointed out the tonsillectomy rate for elementary school children from the education system. The health system didn't have the data. And he showed that the rates of tonsillectomy in children, Margate, 8 times that of Ramsgate next door, fairly similar socioeconomically, Enfield 6 times that of Wood Green, Bath 5 for Bristol, and so on. Extraordinary differences. And some light was shone on this by this, okay, we're missing bits. This lovely study from New York that came out at about the same time, and they took a bunch of 1,000 11-year-olds, and they found that 60% had their tonsils removed. And they took the other 40% and got them reviewed by ENT, clinicians, otolaryngologists, and they reckoned that almost half of those needed their tonsils removed. And then they took the final 20% and they took them to another bunch of ENT surgeons. And hey presto, they thought half of them should have their tonsils removed. And they took them. And by the end, after 3 reviews, there was virtually no child would have had their tonsils. And what this showed was, what we came on to recognize through the work of Jack Wenberg and others at Dartmouth in the 1970s, was that there is clinical uncertainty, professional uncertainty on many aspects of healthcare as to what are the appropriate indications, when should interventions be used, and you get these variations, and Jack and colleagues, this was just one of the early papers in the 1970s, and that work continued through particularly the 1980s and 90s, and culminated in recent years with these sorts of atlases of variation you're probably aware of in many countries, just showing how much variation, mostly focused on utilization rather than on outcomes. And that is sort of where we had got to. Now, the interpretation of some of this variation is very straightforward, in that we know in the differences where we'd want to live, what is good and what is bad. So here's work from the renal registry in this country on renal replacement patients, 1-year survival after their transplants, and as you can see in all the units across the country, there is some variation, actually rather little, but there is some, and there are 1 or 2 units that are on the whole better than expected in terms of survival. I don't think there are any that are worse than the English average. And it can look also much more easily done, because we don't have much outcome data in the health service, on processes. So we can define, or others can, that mothers expecting preterm delivery ought to have antenatal steroids to reduce the risk of respiratory distress syndrome in their neonates. And it was agreed, professionally informed by the scientific evidence, that we should be aiming for about 86%. Not 100%, because there are some women it's contraindicated. And there you can see, this is 2011, it's improved since then, I should say, but then it's just to show the example of process measures, and you had these maternity units down here where you would not want to be having a preterm delivery with only 60% or so of women getting what is known to be a effective treatment. And we can look at another thing where there is good scientific evidence from randomized trials and whatever, that on the whole, hip replacements, you're better to have them cemented rather than not cemented. They last longer and so on, outcomes are better. But look at this, in 2013-14, this was from the start of the Getting It Right First Time, the GIRFT project from Tim Briggs, and again, all the different orthopedic units across the country, and some of them are indeed cementing all the hips. Perhaps it doesn't have to aim for all, but the vast majority. But you've got some down here where they're virtually never cementing the hips. I know which hospital I would want to go to for my hip replacement. The other thing that hasn't been looked at so much, but again is straightforward to interpret as unwarranted, is variation in costs. And this relates very much to what Ash Shah was saying this morning in some of the international work. On the whole, those of us, and I take some of the blame, who worked on variations from the 1980s through, we focused almost entirely, in fact entirely, on variation in clinical effectiveness outcomes, because that is what we thought was the issue, that there was unnecessary or inappropriate, or perhaps actually under treatment as well, and that was the main driver. As Ash showed this morning, it's not actually about quantity, it's the other part of the equation, it's the cost, or price as he used it this morning in the American context. This was some work we did looking at memory clinics where you get sent if you've got cognitive impairment, where we can determine whether somebody's now could be diagnosed with dementia and appropriate interventions. And this is the cost for that first referral and the first 6 months of clinical management. And this is data from 2015, system level costing, bottom-up costing, and even if we exclude the outliers, although all the data was checked, that this really was confirmed that this was £5,000, but there we are. But even if we ignore that and look at the bulk of the ones, 84%, it still varied sixfold for the same process of care. And I can tell you, because we followed up all these patients, the outcomes were identical. So this is not that you're getting more effectiveness from the spending more money. But you've got now. When we got this, I asked around a lot of people, a lot of health economists, what did they think of this? Were they surprised? Most people were surprised at the extent. I said, is this typical? Because it turns out there is no comparable data on the NHS on the variation in the cost of production of care. What we've got is reference costs, which are actually simply prices, more or less pulled out of the air. This is absolutely extraordinary. And when we worry, those of us who worked in the sort of the variation lobby industry, we worried about outcomes varying 20%, 40%, 60%. This is 600%. So in a sense, the focus needs to be as well on the costs. Okay, there is some sort of indication of variation in costs. This is from GIRFT as well, from the ENT program published recently. And you can see day surgery. We know that the outcomes of day surgery for ENT elective procedures is just the same as for inpatients. And yet you've got some hospitals where all the procedures are being done as day cases and at the other end down at 30%. And you can sort of, obviously, there is cost benefits to be got by shifting to more day surgery. Now, yesterday, Nigel used this slide. In a sense, what I've been talking about is the variation down here, where we know what should be done, and there is pretty good agreement amongst clinicians, managers, politicians, it ought to be done. But of course, most of healthcare isn't in that segment, it's up here. What are we going to do about that, and why? What are the reasons for that? Because if we don't understand the reasons, we don't know what we should be doing. And answering that question about, is this variation a good thing, a bad thing? How much are we willing to accept, assuming you could do anything about it? Another suggestion is there are 4 reasons for variation, aside from all that unwarranted variation with a good scientific basis. The first is there's a lack of consensus. We don't actually know what we should be doing. We're waiting for the research evidence to emerge. There's clinical uncertainty, and that's a huge amount of what we do in healthcare. The second is, and this relates back to some of the things talked about earlier in this meeting, is if we want to encourage local creativity, social entrepreneurship, innovation, inevitably there will be greater variation. Are we going to tolerate that? Because you can't have both. You can't have local innovation and say we mustn't have any, we mustn't have it because there's variation. That's got to be reconciled. 2 very quick examples. One of the commonest problems, as you know, elderly people falling rapid response services have been introduced all over the country in different places, locally in different ways. This is a great example from Nottingham, a combination of the Ambulance Trust and the social care, social services in Nottingham. 14% of 999 calls, 14%, that's a huge number, are for elderly people who have fallen over at home. And when they started, half of them were picked up by the paramedics and taken to hospital, and they're in the queues in the ambulances outside A&E or on trolleys. They introduced a falls rapid response team, combining the paramedics, the social workers, and halved the number of people being taken to A&E. Another example, Dennis O'Rourke, integrating commissioner for mental health in Lambeth. He got together in 2013 all the relevant people involved in using mental health services in the community. They developed a thing called the Living Well Network, which isn't time to go into what it was, but it was absolutely bottom-up, local, with amazing results. It now supports 1,400 people a month, 40% reduction in referral to psychiatric services and so on, secondary care services, and taking the pressure off those very overburdened services. So there are some great things that can be done, but that's going to introduce variation. Are we going to tolerate it when we find that variation in the use of secondary mental health care or in the use of A&E is the result of that? There are 2 other of the 4, and the 2 colleagues are going to be talking about these. The first is that a lot of variation is a sort of legacy. It's also context of how things are provided in different areas. And much as we might wish that perhaps every ICS in the country had exactly the same formation of services and configuration and availability, that is not the case. They're all starting from different positions. So that's another source of variation. So what do we do about that? So local context and constraints. And then second, the final one is, and it comes very much back to the Matt Hancock's comments about IVF yesterday. Are we saying that local commissioners have all got to commission, in which case, the same way, in which case, why do we have local commissioners? We just have NHS England commissioning for everything and just telling everybody what to do. Because inevitably, if we want local responsibility for commissioning, people will commission in different ways and variation will result. So, with that background, Luella Vaughan is going to speak first on secondary care.
Thank you very much. I must say, I've been asked to talk about variation in secondary care in 8 minutes. And given that many people in the audience know a lot more about variation than I do, I sometimes think this is a slightly unfair task. It's like expecting 7. Well, there we go. I'm wasting my time with anecdote. At what point is variation acceptable or unacceptable? And I must say, this is quite a difficult topic. So there is undoubtedly quite substantial variation in the delivery of secondary care in England. So we'll talk about England. So these are the SHIMI mortality rates, so the standardised hospital mortality index. If you're above the line, you're not doing as well as you should for your population. If you're below the line, you're doing really well. So there is substantial variation. The response to that at national level has been to find it, hunt it down and eliminate it. And these are all of the sorts of organisations which are involved in either standard setting, collecting data, or punishing those who deviate from the party line. I've tried to kind of group them across, but some of these organisations sit across both. Now, this is not to say that aspects of this endeavour are not entirely worthy, and in fact, it should and ought to be done. The best possible example of this one of the excellent examples of this is hip fracture. We know large amounts about hip fracture. We know whether your hip replacement, and along with this, other joint replacement, what you should do, what sort of joint is better, how much does your joint cost, what sort of approach should you use, how should your team be set up, how should your theatre run, day case, inpatient, what should your physio, OT, rehabilitation look like. There are multiple high quality studies which have been done on this, plus the lovely work of the National Hip Fracture Audit, which has demonstrated real benefits with reductions in mortality, reductions in length of stay as variation has been eliminated. So this is an excellent example of where variation should be hunted down and eliminated. There is no argument with this. A much more interesting example is around stroke. So stroke is a very defined clinical condition. You get a clot in the artery in your brain, which is something that happens in a second, in an instant. The patient can frequently, well, perhaps not the patient, but someone around you, the patient can tell you exactly when it happened. There are excellent high-quality studies done on the critical time intervention of thrombolysis. And there have also been large numbers of studies done around other aspects of care. So again, this is something where the evidence is very clear. And the excellent work done of the National Stroke Audit, hosted through the RCP and for a long time led by Tony Rudd, undoubtedly found that as processes of care got better and individual units got better over time. So this is the graph on the right. So this is the number of patients thrombolyzed over time. That's the volume, that's the number of patients they're seeing the thrombolysis. What you see is a lovely drop in mortality. This is a phenomenal outcome. Stroke patients in the UK did not do well, and now they do very well. I mean, it's still, it's all relative, but substantially better because the mortality is still out around 20%. But substantial improvements in outcome. An observation of this excellent work was that the bigger your unit was and the more patients you thrombolyzed, the better your outcomes. And so the natural corollary of that was, if we consolidate the number of stroke units into a smaller number of units, therefore the outcomes will continue to improve. Unfortunately, this was not actually quite true. So they managed to get some improvement in mortality with the reconfiguration in London, but only in 90 days. Not at the 30 days as might have been expected, as seen from the changes in the other graphs. And the outcomes in mortality were very slow to materialise elsewhere in England, including in Manchester, where there was no change for several years. And so this caused a lot of consternation. There was some excellent research done by Naomi Fulop, who is in the audience, and her other colleagues, including Steve Morris at UCL. And the finding was really interesting, which was that it's not actually just doing what you should be doing, it's the context in which it is done and the other peripheral things that sit around it. So it's all fine to say that you need to get your patient, if your patient is having a stroke, you have to mobilise the ambulance and you have to get the patient there in a timely fashion, then you have to get them into the scanner. But the ways in which you do this are context specific and depend on what your starting point is like and how you manage the change process. And this is something that is known from business change. Half of all business change fails. And then after that, 25% of it doesn't stick. So actually 70% of all change doesn't work. So this was a very interesting kind of trade-off between the things that you should do are clearly known, but actually doing them at scale, doing them at pace, changing things, failed to make the improvements that were expected. And this was because it was around constraint in the change of setting. So this is a slightly more complex example. So as you all know, NHS England and NHS Improvement have been running a series of national programs about how to deliver care at the front door better. Through a whole series of initiatives. In fact, this goes back so long I couldn't even find the logos for some of the previous rounds of this. And it's basically based around, on this side we have, this is the model hospital, so this is all the kind of stuff that you should be delivering as a kind of mosaic of services. And then on the other side we have some of the specific initiatives about what you should be doing at the front door. So you should have, you should have an SDEC, and it should, which is same-day emergency care, which is basically it should have some acute ambulatory care, some acute surgical care. Ideally, it should have an acute frailty unit where the patients are rapidly seen and assessed and turned around. You should have GP streaming. So these are the sorts of things that you should have at your front door. Well, what is the evidence for this? Well, there is no evidence for ambulatory care. So this was a recent review published by Dan Lasserson, who is the Professor of Ambulatory Care at Birmingham. Basically no evidence. Pretty much everybody in the whole of the UK does it. I think 96% of acute trusts do ambulatory care. No evidence for it. GP streaming, hot off the press from my good friend Tom Hughes, who is the National SDEC lead, published in the BMJ this week. No real evidence for GP streaming either. And in fact, at my hospital, we found years ago that the nurses are much better at streaming than GPs. And then we're talking about who does there's two aspects to GP streaming. Who does the streaming and where are the patients streamed to? There was no evidence at our hospital for GPs doing the streaming or streaming into GP, and we got rid of it. And now we have to have it back again because the national evidence says so, despite the fact that our own local data said that it didn't work. And there is no evidence for this. Frailty CGA. The evidence for this is in inpatients, and there is an interesting thing about the contextualisation of comprehensive geriatric care in the inpatient setting. Is it the CGA itself, or is it what happens within the team and the circumstances in which the care is delivered? This is still not being clarified. Undoubtedly, CGA in the inpatient context helps get the patients home and keep them at home. Is it going to be the same if you try to do this in a busy front door unit with staff coming and going without the time taken to see the patient? Is there evidence for that? Well, as yet, there's not good evidence, and David or Tom Downs might care to correct me on that, but my understanding of that is that we are talking about taking something that is proven to work in one setting and transferring it nationally into every hospital in an untried setting. And this is the setting back here that we've shown that it doesn't work for patients who don't have complex frailty needs. Right. So we then looked at some of you might be aware, we've been doing work on medical generalism for many years. And the hospital on the right, so these are both two small hospitals. So these complex diagrams are just basically flows of patients through various bits of the hospital. So this hospital tried to do all the things here, and the flows through the system look like this. So spaghetti. Another hospital, which is about exactly the same size and in kind of the same sort of area, didn't refuse to do any of it and just stuck with ED, bit of ambulatory care, and that was it, and that's all it did. And the interesting thing is that this produces complex streams and flows. I'm not an engineer, so I don't know how to analyse it, but you only have to look at this going, it's hard to have grip on this. How can you have grip from a bad management point of view, know what's going on in your process if you've got this? This is easy to manage, but this emerged because the ED and the AMU are at the other end of the hospital from each other. So you can't actually set your services up any other way. This one, they had a warren of units out the back. They moved their radiology department, and so they put all of these little things in all of the cupboardy spaces left over from the radiology department. But that's what they ended up with. And the really interesting thing is that when this hospital got rid of this, after we showed them this, they kind of went, oh, and they got rid of this, and they went from being an average performing trust on the 4-hour target to being one of the top 10 performing trusts on the 4-hour target. So they have stopped doing what has been prescribed and their performance has improved. Right, so Nick has covered some of these, but I think it's just worth reiterating. One always has to think, how good is the evidence? Really, we're meant to be doing what the evidence says. If there is no evidence, don't do it. And frankly, physician consensus, I'm increasingly thinking, is just not enough. That's a heretical thing to say. But I increasingly think for some things, as Nigel said, just because it's good in Luton doesn't mean everybody else has to do it. I think there's a very interesting issue of factory floor versus bespoke. Those processes which can be tailorised should ought to be tailorised, and processes around how you monitor, are aware of monitor and eliminate variation are completely appropriate. But there's lots of things for which it's not appropriate. If we're talking about personalised care and it's bespoke, you can't tailorise it, you can't measure it, and it would be wrong to do so. As Nick has already pointed out, is what you've got, is it really genuinely variation, which it might be bad, and in fact actually being a black sheep, there's nothing wrong with being a black sheep sometimes, or are you a goat? So actually, how can you tell the difference between these two things? And just because it's a goat also doesn't mean it's a good if you want the wool. So actually thinking very hard about what you're seeing, variation or innovation or poor performance. And it comes back again to context, 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 context. Most of what you do in hospitals is context constrained. We are in an environment where there is not enough of anything in secondary care most of the time. I'm really lucky, I work at Barts, we have lots of stuff. But most organisations are not that lucky. And so what you do the best that you can with what you have. Which leads you to, if you were trying to get rid of variation, you were trying to have all the services the same, to get to there, I wouldn't start from here. Thank you.
On commissioning.
Thanks very much. So it's a hard act to follow. And what I want to do really is pick up from Luella's point about context and really think about how population health shapes context, and actually how, if we do what we're asked to do in the long-term plan and increasingly throughout all our health policy initiatives, respond to population health need, we are likely to necessarily drive more variation. I'm going to use a couple of examples, one from commissioning and one from primary care networks, to explore how that variation might emerge and how we might respond to it, and then just have a very quick reflection on how our responses to variation might shape our ability to maintain professional engagement in the changes that we want. So, just thinking about population health needs, we've got a long and fabulous history in England, in the UK, in the NHS, of needs assessment. I don't know how many of you remember those lovely round commissioning cycles. They were everywhere about 20 years ago. And point one is always population needs assessment. We have got a long history of joint strategic needs assessment across health and social care. And then coming down into the primary care sphere, about 20 years ago, there was a big movement about community-oriented primary care, which was absolutely about designing your general practice and primary care services, connecting them to your local population and addressing specifically local needs. And then I've included the little Rubik's Cube here, which has come out of the primary care home initiatives. The idea being that each subsection of the cube represents a population subgroup with a specific set of needs. And the narrative is that primary care homes should be designing the services that they deliver in order to meet the needs of those specific subgroups. So this has been an underlying logic of all that we've been doing for many years and continues to be so. So what I want to move on to now is an example from my own patch. I'm a GP in Greenwich, about commissioning specifically for variation. So the Royal Borough of Greenwich has just commissioned a new Startwell service, which is about health and wellbeing services for children and young people in the borough. And they specifically put out a tender or invited tenders to deliver 4 locality services shaped according to the specific population needs of the 4 localities that they defined in the borough, but also that had to address the overriding priorities of the borough as a whole. And they ended up commissioning these services from 3 different providers, so one of them is serving 2 of the areas. They said that you have to provide these core services. I won't read through them. That is the essential elements. But the tenders were assessed on their alliances with local voluntary sector groups, with the way that they were going to nuance their services to specifically address the particular needs of ethnic subgroups within the localities, etc. Very importantly, and this ties into what Matt Hancock, I think, was talking about yesterday, I want standard outcomes, but I'm not going to specify the way they are achieved. They have created a list of KPIs that apply to all the services that are standard across the borough. There's a very broad range. It's a large spreadsheet with several pages. It covers inputs, activity, reach into the local population, uptake of checks, links with other services, and various outputs and outcomes. Just a couple of exemplars. So an exemplar of a KPI for outputs is the percentage of eligible families registered with Healthy Start, and a few exemplars of the direct impacts they want to have from the services. So progress against goals in multiple domains. That means you look at where an individual, a family, a parent or a child starts with a particular issue and set goals for how the services will help them to develop and improve. So issues around parenting skills, mental health, anger management, things like that. Percentage of mothers breastfeeding at 6 to 8 weeks, percentage smoking in parents, smoking cessation in parents. So a wide variety of aspirations and some real opportunities in this approach. So they have got a much increased focus on prevention than they had previously. They have identified a range of new priorities for adolescents. They have managed through this approach to preserve children's centres, which have been one of the great successes in the delivery of children's centres. In many areas, they're shutting down. This has enabled them to preserve them, so a lot to be said for it, but also a huge number of challenges. The organisations that are leading these services are not natural healthcare organisations and healthcare providers. They're now going to have to implement services, working with professionals from other sectors. There's a whole load of implementation challenges. There are challenges about quality improvement and assurance. There are challenges about coordinating. Each of the organisations that's running them is going to be working with 4 or 5 others. And then for the commissioners, actually challenges in monitoring whether they are achieving the outcomes that are set out in the contract. So what's going to happen if they don't? What's going to happen if they focus very much on the population subgroups that they've identified in a locality that they want to give particular attention to, but in doing so slip on some of the other outcomes? How long will we give them to kind of all level up? I'm going to come back to that question. I just want to park it, but I think it raises very interesting challenges about once you start to commission for population-defined variation, how far can we then go in the outcomes that we achieve? Oh, I seem to have lost a slide. That's interesting. So I was going to move on to primary care networks. So primary care networks formed across the country, and there is a national programme in place to do needs assessment at primary care network level. So we are creating the data to understand population health need for each of these networks. And PCNs are going to be invited to work out what the needs are in their local population and how they want to address them. These are 2 slides from my own borough. So we have 6 primary care networks. This is mine. It's called Riverview. And the 4th one down, and you'll see that we have a lower number of older people than the 2nd one down, which is Eltham, which is where the large majority of the very elderly are in my patch. So they do a load of home visiting, but we don't. And my PCN has a much, much bigger issue with drug and alcohol addiction, with mental health problems. The average life expectancy at birth is very different. So my patch has the lowest for the borough, a lot to do with suicide, drug and alcohol addiction, etc. So clearly my needs in my PCN, or the needs of the population in my PCN, are very different. So what are we going to do about that? Well, I think we have a number of different ways in which we can respond now as primary care networks, partly in how we recruit to new roles and therefore in the development of the services that are going to follow. So we've had discussions about whether we recruit paramedics who can do home visiting or mental health workers. We're going to recruit mental health workers, but the other patch will be recruiting paramedics and setting up a home visiting service. And a patch that has a very young and mobile and working population may well decide to start investing in digital technologies and creating more digital services. So these variations are going to start to creep in. And I think getting back to the discussion that we started to have yesterday, what will be tolerated? One answer may be nothing. But I think once you get down to these very local levels, we're used to a certain amount of variation. But what will happen if there's a difference in response time? If the Eltham patch has a 2-hour response time for home visits and mine has 5 or 6 hours? What will happen if differences in eligibility criteria emerge? What will happen if some services are present or absent in different parts of the borough? We're kind of used to this, but if this happens more and if it becomes more pronounced, is there going to be any kind of backlash about it? How far are we able to go? And then just a final thought. Coming back to what I said about what happens if the new services that people are going to bust a gut to set up don't deliver the kinds of outcomes that we want. All of them are going to take a huge amount of effort, of resources, of OD support, of professional time and input to develop them. The narratives that are rooted in population health need are very, very powerful with professionals. They are a good way of engaging people. But I think it's very important to note, and we've just seen this with the primary care contract, that actually there are other things that are really important as well, like getting your practice to survive and sustaining primary care. So there's going to be a variety of interests that are going to shape the services that are developed. But if we don't deliver a kind of adequate uniformity, and perhaps we start then imposing a kind of blueprint and saying, no, you've all got to do it like this, what you then risk is a kind of backlash, a disengagement, just participating at the margins from the professionals and just thinking, well, I put all my effort and soul into that. I'm just going to, do the bare minimum and carry on. So those are some of the things that we are likely to have to deal with, I think, as these very local services start to emerge.
Okay, open now for questions and comments on anything that's occurred to you from those talks. These were just some of the sorts of questions that we had imagined might be worth addressing. If unwarranted variation is not acceptable, we're all, I imagine, agreed on that. But how much warranted variation is acceptable? How should innovation and creativity be managed, regulated, actually positively encouraged, which Matt Hancock seemed to be saying yesterday that he would encourage local innovation if it increases variation? And are we making the best use of the variations that exist for quality improvement and service transformation? But that's not exclusive, that's just to stimulate thoughts. Anything you've heard about, and I can already see 1, 2, 3. So John, Andy, and then Peter. So.
John Appleby, Chief Economist at Nuffield. Thanks, Nick. I've written down about 24 points and one question. Is that okay? No? Okay. All right, just a couple of things. I think we just got to bear in mind that reducing or even eliminating inequalities is not a costless thing. It's maybe a massively desirable thing to do, and we can be really offended at the sort of variations you've pointed out, Nick. And virtually everywhere you look in healthcare, there is some variation, including the reference costs, by the way, even allowing for their slight approximation to reality. But we really must bear in mind that it's not a costless thing, which means what value do we put on reducing inequalities, and what are we prepared to give up, especially in terms of efficiency, to reduce inequalities? and you know, until we, in a sense, measure that value that we place on reducing inequalities, we're just stuck at this position, not knowing quite how much to invest in doing it. A lot of these inequalities you put up could be massively reduced to within insignificant statistical levels, but it will cost a lot of money. Yeah, just one other thing on the data issues. Those sort of S-shaped curves that you can, you plot health authorities or PCTs or CCGs or whatever it is, or hospitals, you get this shape of curve. Just a plea for putting confidence intervals on all of those things. You can be a bit misled sometimes in thinking this variation is significant when it's not.
Andy.
Andy Cowper from HSJ and Health Policy Insight. Thanks for the 3 excellent presentations. If I understood the Secretary of State's speech yesterday correctly, he was saying that he's going to encourage more local variation, provided you don't do anything so mad as to vary the number of IVF cycles that people have. Could you just offer some practical thoughts for people in the room and beyond who are watching this being on the web about how you would go about resolving that tension in practical terms?
Okay, and Peter, and then we'll have some answers.
Thanks. The point I was going to make is from the perspective of a researcher who has often been criticised for not providing really good evidence on some of these. And I think, Luella, you showed that there are lots of sources of variation, that it's really difficult to know what the outcome is. And the lack of evidence does not mean there are no implications of the variation. It's just that the research hasn't been feasible. So what we really ought to be doing is learning from the variation. And so I wonder whether you see any scope for actually being more properly scientifically experimental about variation, and being able to provide evidence from this, from the sort of things that Rebecca has described, which actually are capable of being evaluated and which other people can learn from if they so wish, rather than having this constant refrain that there is no evidence that this is better or worse than some other approach.
Okay, let's, John, so the value we put on reducing variation. Any thoughts on that?
I agree. I think you can chase it down to the nth degree, but would it be your priority? And in one sense, that overlaps with how I would respond to Andy's question, which is, I think these are the decisions of local commissioners, taking your population health needs in the round. How far do you want to go on, delivering one type of service or not, and accepting the opportunity cost of another, or investing in reducing a variation, but then having an opportunity cost of that. And I can only sort of surmise from what we heard yesterday that there may be some interventions for which there will now be a national number, because they're high profile and create a lot of social media storm. But I hope it won't be everything. I hope there's going to be remain local discretion for the kinds of decisions that have been made in Greenwich that I told you about.
So my one of my other research interests is in the issue of smaller and rural hospitals. And I think that this kind of issue of elimination of variation and how much do you spend really interesting. Because of course the studies have been showing that what everybody wants, no matter how rurally you live, is the Mayo Clinic at the end of your street. And there has become an expectation in the norm that actually a large quaternary hospital sitting locally for you, which is going to do everything for you all the time, is in fact the norm of care, when actually the norm of care in most countries, in most places, which actually get better healthcare outcomes than the UK, is a kind of a well-resourced DGH, which is there to take care of you with your chronic disease and your chronic comorbidities, and is interlinked into the general practice and actually provides you with holistic care. And in fact, the sort of the Death Star model of care is the exception rather than the norm. So I think there's this kind of interesting question around the issue of whether exceptional care should be the norm, or actually very, very good quality care, which I think is what most people want, is what's actually fair and more equitable and actually produces better results probably in the long run.
Okay. Picking up, Peter, your point, if I've understood rightly, I mean, talking with Al Mully, who's one of the doyens of this whole area, going right back, working with Wenberg and others yesterday, we were reminding each other that the reason that we spent so much time highlighting variations was a way of capturing politicians' and policy makers' attention to the fact that the status quo was probably not acceptable and was not the best of all possible worlds, even if we didn't know which end of a variation spectrum was the good end to be, the first step. Now, in some ways, that has been incredibly successful. It's also had the seeds of a real problem, because fairly early on, the politicians, I distinguish them from the policymakers in terms of, I think this morning was used wonks, but the civil servants, the informed people working on the data who got it. But a lot of the politicians immediately assumed that variation was a bad thing. Now, clearly, in that bottom left-hand quadrant of Nigel's graph, it is a bad thing. We want our hips cemented, we want antenatal steroids. But for the vast majority of healthcare, it doesn't lie in that quadrant, but that didn't stop the politicians thinking all variation is bad, we need to move everybody. Often it was actually bring in the extreme, the average was what was desirable, which is highly dubious. So in a sense, the research community, we were responsible for alerting the system. The system grabbed variation. The atlases were the sort of the greatest manifestation of that in some ways. So that was a success, but it's also some of the problems. But Peter, are you saying we ought to be making more use of variations for research through natural experiments and so on, and that perhaps we're not making as much use as we should be?
I think the point I'm making is that we need to be able to answer those politicians' questions, and either to say it really doesn't matter and actually it should be a matter for local thinking, or to say that it does matter and we should do something about it. But actually what we tend to find, this is a slightly techie issue, but actually the areas that adopt one process are self-selected. So it's quite difficult to compare them with the areas that don't adopt that process, because there are all sorts of confounding things that mean that it might not be the process that's the reason for the different outcomes. There might be other reasons for that.
Yeah, so I'm very interested in this question because I'm actually trained my background is that I am a doctor, but I'm trained as an historian. And actually the whole entire point of history is that the context is never the same. So certain things will always be the same, but it's never directly applicable. And that actually in medicine, the constant pursuit of finding or comparisons between particular sites in which the context is never the same and therefore can never be the same, and therefore the lessons are only vaguely generalizable rather than universally applicable, is actually completely fine in history, but it's not actually fine in medicine. And there's this kind of interesting tension, I think, within health services research around the fact that the results of many studies are the same over and over again, which is if you had more time, you had more money, you had better leadership skills and people got along, actually everything would go much better. But the question is, how do you do that? And every single airport bookshop is full of a whole entire wall full of books, which are constantly changing, which tells me how I ought to do that. And so I think that there's something in this about where we run up against complexity, against human nature, and the mystery of being human. And I quite like that because I'm a historian by background, but I think it creates interesting problems with it. And to a certain extent, I think that we would just have to say there are certain things that are unknowable, and we have to be comfortable with that. And actually, we have to look at the outcomes rather than sometimes being quite so obsessed by the process and being able to replicate process, because it's never the same. It's always contextually constrained.
Yeah. I think the covers of the books are changing. I'm not sure the contents. There's somebody over here. There's somebody with them. Al here and here. And then we'll come to the other hands after that. Let's take those three. Yes.
Is it on?
Yes.
Yeah, okay. So I'm Anita Donnelly. I'm the ex-chair for 3.5 years of the Mid and South Essex STP. And my question is a lava lamp related one. So we seem to have replaced what used to be the obsession between strategic health authorities, then every 7 years the lava lamp size would change, the bubble would then go down to regional health authority or whatever. We seem now to have replaced that with something at system versus place level. And my question is this. The panel have made a very, very strong and entirely impassioned and correct presentation based around identifying local population need. At what point do they think it is reasonable to retrofit a system-level evaluation framework, trying to reconcile some of the Health and Wellbeing Board strategies on a 5-year horizon, council plans that often on a 30-year horizon for populations, to establish something which is an evaluation framework that will enable system leaders at ICS level to begin to contemplate their SOS strategy. And the SOS is for system oversight and scrutiny, coming soon to an ICS near you. I'm sorry it's quite a long-winded question, but I think it's quite interesting how we started off saying system would bind all these things together in some glorious world. And now we're talking, again, in much more detail, much more granularity, and much more reality about things that happen at place level.
Okay. Where were we? Yes.
Hi, Catherine Scott from the British Psychological Society. My question's about workforce again. And I think we've been working advising on the people plan. And one of the things that is kind of replicated at that level is in terms of the people plan is going to set at a national level certain standard things. So a leadership compact, which will be dictated from central and dictated is possibly the wrong word, but shared from that level down, and it's up to the individual organisations to adopt it themselves. Similar thing with a kind of well-being offer for staff, for NHS staff. And that, again, there's going to be variation in the way that those things are adopted and rolled out and implemented across the NHS. And again, it does play into patient experience, because happy staff, happy patients, essentially. And I think that's another question, like how much variation are we willing to accept in terms of how staff are supported, treated, services that are there for them. And so I think that's part of my question. And then the other part on workforce is a little bit about, so thinking about psychological services particularly, the nature of what we can deliver is dictated to some extent by the makeup of the multidisciplinary team that is delivering that. So thinking about what kind of workforce models might be, set at different levels and how that might impact on outcomes is another question.
Okay. Al?
I'm afraid this falls into the category of Alastair Campbell's concern about when your board's saying something, people may just begin to be listening, that Nigel made yesterday. And I want to make three general points that relate to the conversation between you and Steve, Nick, and then talk a little bit about context, and I'll do it quickly. I think if you're trying to engage a PCN or at an ICS level, people in thinking about how to learn from variation, you can start with some questions. You can start with, is variation seen as a source of learning in your locality or in your organization, or does it elicit fear of judgment? In 2000, I was asked by Richard Smith to write an editorial in response to publication of the first league tables, and it was titled, Use Variation for Learning, Not Judgment. We learn from variation in outcomes and costs by making visible underlying processes. We learn from variation in per capita rates by making visible underlying professional consensus or individual preferences. The second point is the question is the distinction between warranted and unwarranted variation understood and respected in your organization or your locality? That was a distinction made in 1980, and it was meant to distinguish between a decision that was sensitive to evidence, probabilities of different outcomes, and decisions that were far more sensitive to what the economists would call the utility or disutility of the outcome for the individual. and its timing and the associated risks in the decision. The third is context respected at the level of the system and the level of the individual? What is it that shapes preferences for an individual? It's the context in which they were born into, aged, formed, and all of the experience they've had in the process. We talk an awful lot about ACEs now. That's a context for an individual. And it shapes the way they see the world in many ways, and we're trying to figure out how to respond to that. So the point I'm trying to make here generally is I don't see necessary trade-offs but between learning from variation and addressing inequity. In fact, I think it is the key. It's the people who are dealing with deprivation who we need to learn most from by trying to understand the context in which they live their life and the way that's shaped their preferences and what matters to them.
Okay. The issues raised vis-a-vis a sort of ICS perspective and strategic.
Yeah, I was trying to think how to answer that. I mean, it's so difficult because in one sense, the strategic vision should be translatable down to a local level and then implemented in an appropriate way at place level. But their context is all. And I think one of the things I have found most bemusing in the clinical side of my existence is when a plan is given to me that makes the assumption that I can go from our current performance of, on the 25th centile up to the 80th centile. Major financial models are built on the savings that are going to be made, and nobody takes account of whatever context it is in my own local patch that is going to help or hinder that. And I think that's where we need to get more thoughtful about how we translate the ICS type plans that are now emerging and really think of them down at place-based level. And we have an assumption, I'm in South East London, we have 6 boroughs, we've got a percentage of shift in outpatients that we are meant to achieve. And actually probably that does need to be nuanced at local level, disentangled, some real thought given to it, but we've never proved ourselves. In the last few years, we just have this where you're going to make a 60% increase in the next 11 months, and we're going to take 45 million out of the system. And I think that's where we need to challenge ourselves. I guess I don't know if that properly answers your question about the interplay between the two, but I think we should push ourselves further on the assumptions and expectations that we come up with.
The workforce issues raised. Do you want to pick up that one?
Yeah, so I think this is really quite interesting because when we talk about workforce and the nature of work, there are several sets of factors which operate at various layers. And one of the big problems with the NHS is the NHS is absolutely terrible at workforce hygiene. So the basic notion about signing up to the organisation, is that smooth and easy? Do you feel valued when you get there? On the day that you arrive, particularly if you're something like a junior doctor and nursing staff, do you know where you're meant to be? Do you have a badge? Are they going to pay you? Because frequently they don't. I know of doctors who take 6 months to be paid for the first time. What about your car parking? So all of, do you have an office space? Does your kit work? Are you raging in frustration because nothing in the organisation is where it's supposed to be? So the NHS has this kind of layer of frustration that's almost built into kind of the nature of all workforce. And I think that some of the things that are discussed in this, it's not labelled as hygiene, it's labelled as workforce in the offer. But that's really what they're talking about. They're talking about the basic nature of what it is to go to work and what is your environment like. I then think there's the really interesting issue of all work in the NHS, in fact, in many medical settings, is very heavily siloed around professional discipline, which comes back to issues around regulation, which in many ways is perfectly appropriate. But in a situation where you have a workforce crisis, then proper interdisciplinary working is critical. So actually breaking down some of those problems across disciplines and actually beginning to work together in better ways is enormously problematic. And the research around this suggests that when it is done well, it's transformational, but it's not done very well in very many places because it's really difficult to do. And it takes money and it takes time and it takes shared space, shared goals, shared vision, leadership, all the things that we've discussed that are much easier to talk about than they are to ever actually enact. And then I think there's the really interesting issue of a lot of services actually dependent on getting the right person into the service at the right time. Now, your whole entire service can't depend on Jan being there every day because, you know, some days Jan's going to be off sick and at some point Jan's going to retire. So you can't build your whole entire service around that. But actually using people's strengths and interrelationships much better. And you know, we've been to a hospital down in the south of London where actually all of the doctors all work in teams of pods. So people are kind of divided up around their strengths and their interests, and then they're paired with people from other pods. And some of those pairings are dynamic and some of them are set. But actually in this way, you get more out of two doctors than you would out of two doctors. You get something that's dynamic and is much better for the patients. And I think we need to be really smarter about thinking about that kind of thing. But of course, again, that comes back to this issue. It's easy to talk about it at national level, but it's much harder to deliver at local level. Because we don't really, you know, at the moment, it's not yet fully understood and it's only partially articulated. But focus on hygiene to start off with, and then how do we actually better use each member of our workforce given what a valuable resource they are, I think is a really interesting question.
Okay. Al, picking up your point, if I sort of try and combine the three bits together, it seems to be the common thing, as I understood from what you were saying, is in a sense is when information on variation lands on policymakers, managers, STP chairs' desks, what are they meant to do with it? What happens? And I think you're right. There is probably insufficient understanding of the concepts of warranted and unwarranted variation, insufficient realization about. Now, actually, I was going to say insufficient realization of context, but actually I suspect the managers are very well aware of context. But it's bringing it all together, and that comes to point, what is the point of all this variation work that we can do? The data's there's more and more of it. And that seems to me to be, it was what it was always about, but we need to perhaps readjust. It's a trigger, it's a disruptor, to get people to think, why are we doing it that way? Because most people, individual clinicians, all believe the way they do something is the way all their colleagues do it because they don't see what they're doing. It's understandable. Everybody thinks the way they're doing it is the way everybody does it, every walk of life. So that if nothing else, it acts to disrupt and think, oh my God, we're here on this spectrum of things. Other people do things in different ways, and it may be the workforce use, all sorts of things. It may be the costs. It could be all sorts of stuff. And that is simply the trigger for the debate when the real issues start being addressed as to why, and are we comfortable with that? Yes, carry on. Or let's change things. I can see you're dying to come back in. I'll let you come back in and then we'll take very quickly. There's one more question up here.
Just very quickly, where those 3 points point, where those three observations point is to measuring the quality of decisions that are made. When there's susceptibility to warranted variation, when the decision depends upon knowing what trade-offs somebody is willing to make or not, measure the quality of the decision. Every high-quality decision, if you measure it and you can designate it as such, then gives you the critical information that commissioners need and don't have.
Yep.
Which is, what is it that people want and need when they understand the trade-offs?
Becky, answer while you get the mic to the last
very
person.
quick observation on that. I think one of the difficulties is that what gets counted as warranted and unwarranted variation can sometimes fail to take account of context. So, you know, the GERFT initiative around high-volume cataracts, you'd think it's a no-brainer. Yes, of course, why isn't everybody doing 8 cataracts or 10 cataracts on a list? But in some areas, it turns out, all the simple cataracts are being done in shop fronts somewhere or GP surgeries by entrepreneurial GPs, and the ones left in the hospital are really, really hard to do, and you can't actually do 6 in a list or 8 in a list. And so that narrative that we have about warranted and unwarranted has to go back to context. So it's a, yeah.
Okay, last question, comment.
Thank you. Well, two things, and I think that we haven't really picked up in this debate, but I think reflect very much back to Rebecca's very original observations in the presentation. There's a difference, and there's definitely a difference in the public mind and the way they discuss this, and we've explored this a lot with people, between variation and the floor. So, I mean, in your patch, you've still got 1 in 10 people are over the age of 65. It's less than your neighbours, but still a good chunk of the population. Can they get a home visit or not? That's the flaw. So I think people accept that, for example, there may not be the resources put into it that there might be into your neighbours because there's a difference in the sort of nature of the population, and that's fine. But there should be a flaw to that, and actually it shouldn't be the case that anybody in your patch can't get one when they need one. So I think we need to differentiate a little bit between variation, what's the variation and how warranted or unwarranted might that be, but what is the absolute minimum that people expect and should expect. And I guess then that feeds through into a second thing, which again you picked up, but we haven't really explored. And it's certainly, I think I've got a lot of anxiety around it, around the population health management approaches, is that data doesn't answer questions we don't ask. If we don't collect data and then we don't ask the questions of it, and what we collect and what questions we ask absolutely reflect our own biases, then it doesn't answer those questions, and therefore we don't know. And I mean, just to pick a really quick example of this, there was a long sense of a view that despite all the anecdotal evidence, et cetera, that older people pretty much had a good experience in hospital. Because when we looked at patient experience data for the over 65s, it was better than everyone else. And you thought, well, that can't be true. And it was actually only relatively recently people that actually interested enough to go and ask that question. Of course, lo and behold, what you find is that no, younger older people in their 60s and 70s with less complex conditions are responding, and they do have a better experience. Older people with disabilities, frailties, dementia are actually having quite a poor experience. But we never knew that because we never asked that question. So I think we have to, and that's my anxiety, that are we missing out big groups of people here because we just don't ask?
Okay. We're going to take that as a comment on it rather than a question, partly because I must hand over to Nigel to close the summit. Nigel.
Thanks. Thank you, Nick, for pulling together a very interesting session. So we've come to the end. And what we normally do at this point is try and pull out what the themes. There's quite a lot to take away, isn't there? We've talked a lot about variation over different sessions. We've talked about the importance of generalism quite a few times, the legitimacy of some of our decision processes, the groups who've been neglected. But I've just thought, did this last year, invite anyone to just sort of say, what's one thing they might take away that they've learned, surprised them? They might have learned it from someone on the stage, or they might have learned it over a conversation over coffee. But anyone like to give me a thought on that? We have a microphone again circulating. Yeah, Fazina, right at the law of microphone handling says that the person furthest from the microphone puts their hand up. So, yeah, thank you.
Hi, thanks. Well, it's been a great summit. It's been my first one. And I think what I've learned is that I need to know more about policy, because for me there's still a bit of a disconnect between what's happening at policy and what I'm trying to do on the ground. So I think I need to know about it, and I want to bridge that gap.
Although you might remember what Bismarck said, that no one who is interested in policy should ever, it's like sausages, you should never watch it being made. But thank you for that. It's a great observation. Anyone else got something that I can't really see? Masood is there. Also now furthest from the microphone again on behalf of the operation. Good.
I was surprised about international comparison and USA data, because at aggregated levels, we have got one vision about US healthcare, but when actually you break it down, it's completely different, and that really took me by surprise.
Yeah. Everything is slightly more complicated than you think in almost every field, isn't it? Anyone else got any other thoughts? Yes, as Sean, I think, yeah.
Thank you for a great summit, Nigel. I was struck by, first of all, Chris Whitty's fantastic speech, and particularly his stats on outpatients, and that it's not all about old people, which really landed with me. And then also, just as an aside, the Luella mentioned the streaming and no evidence for streaming when GPs in emergency care. And I think that touched a theme for me, which I've heard over the 2 days, around some of the decisions and policies being imposed from above, which people seem to be questioning in this room. And I just wonder how that translates outside this room in everyday practice. And that maybe I'm bringing my own bias there, but towards the regulators. But I just found that that's a theme I've heard lots of people mentioning.
Yeah, great. Can I ask you to fill in your evaluation forms now? And we'll take another comment from Eileen while you're doing that, but we'd like you to complete them. They're very important to us. So we'll go to Eileen, and then we'll come to Richard. But if you could do your forms while we take those comments, we'd be very grateful. Eileen.
So 2 things. I think the first speaker this morning needs to send his slides to the people who are going to be doing the trade negotiations with our American colleagues, because I don't know if people were struck when there was all the furore about America's going to take over our NHS, which was nonsense, but there definitely was the American ambassador saying, why do our American patients pay so much for their drugs and you guys in Europe get them so cheaply? And no sense of the Americans should be paying less, a sense that we should be paying more. So I think we need to get him to send his slides to the Brexit negotiators, or the American negotiators. And the second thing is, it is all about old people. It's not only about old people, but it's especially about old people with dementia. And we haven't talked about that at all here, but services for that group from health and social care are poor and are causing huge numbers of people to default into hospital and get stuck there. So whilst everything else we've talked about is really important, we mustn't get a bit bored and think, oh, we've talked a bit about old people and now it's time to move on. It's still really important.
Great, thank you. I'm noticing some of you not doing your evaluation forms. I'm trusting that you've done them already, so no pressure. Richard, shall we come to you? There's Richard here, and then we'll move on.
So I'm sorry, I was struck by the sort of the consistency of the message from the representatives of the government whom we had speak to us, compared to the diversity and complexity and nuance of the conversation coming from people who are actually doing the work. And I suppose I always knew that was the case, but I hadn't had it quite so consistently displayed to me in such a short period of time that I could notice it. And I'm still backing the people who are doing the work.
Thanks for that. History has been one of the themes of the. It's kept coming up, hasn't it? Which is interesting. On your tables, we've got a little description of what we think our strategy is. It's quite a quick and good read, which will tell you a little bit about what we're doing. And we focused a lot on. We're really focused on things which we think are really important but not sufficiently studied, and where you think there's something important to say. It turns out that some things which are important, not studied, that there's limited things you can get your teeth into. But one of the reasons why we looked at prisons, because it fits that category. Children, young people, actually, we think are still in that in that category. Workforce, of course, and social care, but also history. We've taken over. Some of you might be familiar with Geoffrey Rivette, who wrote a history of the NHS for the King's Fund, and then kept it up to date for the next 20 years on a homemade website that he's created, which we're now taking over. It's called nhshistory.net, and it's going to be on the Nuffield Trust website. And we're hoping to build more history resources. We're going to be working with the Health Foundation, I hope, to bring together some of the academics who work in this area, but to try and fill some of the gap in the NHS's very poor historical memory, so that we can use history as a policy analysis tool, as well as recording that. We're also working with the European Observatory on Health Systems and Policies to provide us and with the Health Foundation on getting a better documentation of what is happening at the time. But of course, it's always important to go back and study that. So we'll be launching this fairly shortly, and it's been moved from this 1990s website with radio buttons to something a little bit slicker. It works by decade, so it has a chronology, and it's pretty searchable. It's missing a few thematic things that we want to try and see if we can fill the gaps on. So we'll be working to do that. I hope you've enjoyed the summit. I think it's been fantastically interesting. If you're interested in working with us or coming to the occasional small seminar that we run, do get in touch and tell us. If any of you have got an idea about what we should call this event, I'd be really grateful. When it was first set up, before I joined the Trust, it had much more of a feel about sort of getting the sort of top officials from NHS and Department of Health to come and talk at people. And we've moved it, you may have noticed, to something that's more like a really interesting and quite eclectic group of people who represent all sorts of different interests and points of view. So it's not really a summit in that sense, it's more of a salon. But that doesn't sound right either. If you remember those 18th century salons, they were run by women. This one's run by women. And it brings together interesting people, but it doesn't quite have the same. Symposium sounds a bit pretentious. Colloquium, even more so. Agora, they have in Europe for this sort of thing. In the EU, they call this an agora, marketplace. But if you have any ideas about what we might call it, because it might be sensible. The summit sets up a slightly different expectation, but maybe then we can actually meet, and maybe doesn't quite reflect the nature of the event. A final thanks to our partners, Optum, MSD, and our media partner, BMJ, I said last night, excellent to work with. And a particular thanks to our AV team, the conference organising team, and indeed to the hotel staff, who I think you'll agree have all done a fantastic job, despite the competition for the frequency that we're using on the radio mic. Apparently somebody else is illegally using it, so that's why we've had this cutting out, which is a shame. But I think you'll agree they've done a great job with the logistics and putting together a fantastic event. At least I've enjoyed it. I am now going to go home and lie down, and I suggest you all think about doing the same. Lunch will be served next door, and we hope to see you next year. Thank you very much.